The committee will come to order. Thank you, Secretary Becerra, for testifying today before the House Ways and Means Committee. The President's 2024 budget doubles down on harmful policies that will only make access and affordability of care worse, killing new medical innovation, false promises of Medicare solvency with real consequences, and more reckless spending on government subsidies for the wealthy. The President's new budget expands Democrats' harmful drug price controls, which means higher prices for new medicines, according to the nonpartisan Congressional Budget Office. Regular folks will have less access to care and fewer new drugs, up to 342 fewer, according to one study, with medical researchers already announcing suspending work on treatments for a rare eye disease and certain blood cancers. On top of fewer and more expensive medicines for seniors, President Biden's budget also cuts Medicare. For example, under current law, Medicare faces $500 billion in cuts created solely by Democrats' spending spree. The President's new budget presents no plan to stop them and threatens seniors' hard-earned benefits. It also proposes significant changes to Medicare Advantage, which may negatively impact the 31 million Americans who rely on the program. These seniors who prefer Medicare Advantage plans need assurance from the administration that their cost, coverage, and access to care will not be impacted. Republicans are committed to protecting and strengthening Medicare, which is why last week, all of the Republicans on Ways and Means and Energy and Commerce sent you a letter about this issue, and we look forward to your detailed response. Additionally, this budget continues welfare for the wealthy by proposing another $183 billion in new Obamacare subsidies for wealthy people making as much as $600,000 a year. These Washington subsidies are a cause of inflation, not a solution. I represent rural, working-class communities where access to health care is a major challenge. Health clinics and hospitals are struggling to keep their doors open to treat patients. The Biden administration must prioritize better access to care for rural Americans. Thanks to the President's policy failures, our economy is still struggling, and his refusal to change direction will only further undermine Medicare and Social Security. In fact, a University of Chicago analysis shows the President's low-growth policies will reduce Medicare and Social Security financing by as nearly $900 billion, another direct threat to seniors' health and retirement at the hands of this administration. This budget rehashes the same mistakes of more government price controls, false promises to seniors, and billions more in subsidies that drive healthcare inflation. House Republicans want to lower costs for working families, improve access to quality care, and protect Medicare. The Biden administration should work with us to achieve these goals. I'm pleased to recognize the gentleman from Massachusetts, Mr. Neal, for his opening statement.
Thank you, Mr. Chairman. We want to welcome back to the Committee on Ways and Means a distinguished alum, another success story that comes from the Ways and Means Committee. It's an honor to have you here, Mr. Secretary. When you testified before us last year, our country was in the midst of an unprecedented economic recovery from the financial impacts of COVID-19. Today, that progress continues. 2 years of consecutive economic growth, wages rising, and the strongest jobs record of any administration in history. And we've accomplished all this while our colleagues on the other side have been promoting the idea that somehow we're in a recession and launching partisan attacks. We are raising the first generation of Americans that only know life with the Affordable Care Act. What a story this has turned out to be. And now it is baked into the American economy. At life's most vulnerable moments, they don't have to fear any longer that their insurance company will cut off their coverage or being denied coverage because of costs or pre-existing condition. They only know health coverage is free from discrimination for those with pre-existing conditions and women. In the last 13 years, we've given Americans peace of mind, and we're not going back. Democrats have supercharged the ACA over the last decade, lowering health care costs, reducing prescription drug prices for millions with the American Rescue Package and the Inflation Reduction Act. Republicans on the other side have repeatedly attempted to repeal without a replacement opportunity to the ACA. President Biden's fiscal 2024 budget shares the Ways and Means Committee Democrats' commitment to building a historic progress that the last Congress made. This budget responsibly invests in affordability and accessibility of care, giving Americans more breathing room while reducing the deficit. Simply put, this budget puts workers and families over the well-connected. Mr. Secretary, we hope that during this afternoon opportunity, Republicans might unveil what their budget really looks like. We eagerly await that opportunity. This is how you build an economy from the middle out and the bottom up, further expanding Medicare's ability to negotiate drug prices, permanently extending premium tax credits, strengthening Medicare, improving its services, building on the American Rescue Plan's investments in child care, and addressing America's mental health crisis and closing our coverage gaps for Americans living in states that have not expanded it. Other Ways and Means priorities include the President's budget, investments in elder care, TANF emergency funds. We will protect our most vulnerable citizens. Democrats know that investing in health care and caregiving is an investment in our nation's children, families, and economy. Many on the other side have yet to attempt to send this health care system back to the grim days when tens of millions of Americans were without health insurance. That plot to repeal the ACA or the Inflation Reduction Act while making deep cuts to Medicaid would devastate millions. Their plan pulls from the same unsuccessful playbook that they've been pushing for the last 13 years, shifting cost onto patients, sending the healthcare system into chaos, and taking away protections relating to pre-existing conditions. Our colleagues have made it clear where they stand, and let me tell you, it's not with the American family. It's the companies who profit hand over hand and fist over fist from life-saving medications, and the top 1% continue to get billions of dollars in tax cuts in exchange for health care coverage. Ways and Means Democrats have stayed the course, strengthening America's health care, even as that coverage has been threatened to be taken away by the other side. Countless lives have been saved. During my opening statement, I've used the opportunity to remind all of the success of the ACA, the success of Medicare, the success of Social Security, and just as importantly, a reminder that Medicaid has now become, as we've discussed in the past, a very important part of planning for long-term care for the American family. 57 cents on every Medicaid dollar now goes to long-term care. As you know, Mr. Secretary, as we are delighted to have you here on the topics on which we agree, I'm also going to use my question and answer period to talk about what this committee did of historic purpose with the whole idea of surprise billing. Mr. Brady and I fully were on the same page. We know exactly what we intended with the wording choice. And I hope that based on the conversations we've had and the court decisions that have been rendered, that we'll be able to travel down that path in the next few hours. Thank you, Mr. Secretary, for your presence, and thank you, Mr. Chairman.
Thank you, Ranking Member Neal. Today's sole witness is former Ways and Means colleague and is the Secretary of the Department of Health and Human Services, Xavier Becerra. The committee has received your written statement, and it will be made part of the formal hearing record. You have 5 minutes to deliver your oral remarks. Secretary Becerra, you may begin when you're ready.
Mr. Chairman, Chairman Smith, Ranking Member Neal, and to all the members, thank you very much for the invitation. Great to be back in the room. I see my chair somewhere around there. A lot of things have happened in the years since I last spoke to you about budgets. More than 16 million Americans have secured health insurance through the Affordable Care Act marketplaces. That's an all-time high, to emphasize what Congressman Neal had mentioned. Altogether, more than 300 million Americans now carry insurance to cover their health care. That's another historic high. The President's new lower-cost prescription drug law has capped insulin at $35 per month and made preventative vaccines like flu, COVID, shingles available for free under Medicare. Moving forward, this new law gives us the right to finally negotiate for lower prescription drug prices for Americans. To cap it all off, the Biden-Harris administration has safely and effectively executed the largest adult vaccination program in U.S. history, achieving nearly 700 million shots in arms during the COVID pandemic without charge. The FY 2024 budget proposes $144 billion in discretionary funding and $1.7 trillion in mandatory funding for HHS. It positions us to tackle the urgent challenges we face, including a growing behavioral health crisis and future public health threats. It also funds operations and mission-critical infrastructure needed to build a healthier America, moving the nation from an illness care system to a wellness care system. An illness care system leaves our most vulnerable families behind. A wellness care system invests in providing the full spectrum of health care to all Americans. Illness care allows the price of prescription drugs to skyrocket. Wellness care starts by prescribing fruits, vegetables, and exercise. It treats food as medicine. Illness care requires you to get a referral by your family physician to see a specialist for mental health services. Wellness care? Well, it lets you get mental health care the minute you walk through the door of your family physician's office. Illness care forces hardworking Americans to deplete their life savings to get that long-term care that they need, and this is the point that Mr. Neal was stressing. Wellness care, well, it invests nearly as much as it can and as early as possible in long-term care, like in-home care, so our older adults and Americans with disabilities can thrive at home and in their communities. Our budget invests in wellness care. We invest more than $30 billion to prepare for the next COVID or public health crisis, including $1 billion to replenish our nation's strategic national stockpile. On behavioral health, too many of our loved ones are dying from suicide and overdose, so we increase access to crisis care. We grow the behavioral health workforce, and we beef up substance use services. We're also gearing up to handle more than 6 million additional contacts from the people who are experiencing a mental health crisis through 988, the 3-digit suicide prevention lifeline we stood up last year. This budget covers 2 million adults left out of Medicaid by their home states and extends tax credits that make health care more affordable for millions of Americans. It would also ensure that expanded postpartum Medicaid coverage for a new mom and her baby is here to stay. The President's budget not only strengthens Medicare for today's seniors, but protects and strengthens it for the next generation. We also take care of our family members in this budget, investing $600 billion in child care and preschool programs and $150 billion to strengthen Medicaid home and community-based services. This budget funds the Cancer Moonshot and ARPA-H. It invests in Title X family planning programs essential to so many of our families. It delivers on our commitments made as part of the National Strategy for Hunger, Nutrition, and Health. It opens more community health centers. And important to me as a former Attorney General, it bolsters our healthcare fraud and abuse detection and enforcement work. And of course, the President's budget honors our responsibilities to Indian country with more than $2 billion in new resources in 2024. This budget reflects the President's and our values and commitments. It helps begin the move from a nation focused on illness care to one about wellness care. And most importantly, it ensures health and wellness are within the reach for all Americans. On behalf of the women and men of HHS, we look forward to working with you. And Mr. Chairman, we thank you for the time, and I yield back.
Thank you, Secretary. As always, we want to make sure that all members have an opportunity to ask questions of the Secretary. Therefore, without objection, each member will be recognized for 3.5 minutes to accommodate the Secretary's time. We will now proceed to the question and answer session, and I'll begin. In the Inflation Reduction Act, Democrats gave your department $3 billion to implement a drug price setting scheme, which will undermine innovation into life-saving drugs and increase the cost of new medications. I, along with the ranking member of the Senate Finance Committee, Senator Crapo, as well as House Energy and Commerce Chair Kathy McMorris Rodgers, have requested detailed information on how your department plans to spend the $3 billion. That was sent to you more than a month ago, and we only received your response just mere minutes before the hearing began today. Will you commit to keeping Ways and Means regularly informed by making appropriate HHS officials available to testify before this committee about the drug pricing scheme so that we can have more effective oversight over what I fear will be more government expansion and control?
Mr. Chairman, we are absolutely committed to making sure that in implementation of this new prescription drug law that allows us to negotiate for better prices and increase competition, that we will absolutely keep this committee informed.
Thank you, Secretary. The President's budget claims to add 25 years of solvency to the Medicare program, but it is all just budgetary sleight of hand. The President's budget does have $650 billion in new taxes on small businesses, but then you use that money to claim both shoring up Medicare's trust fund and deficit reduction. You are putting budget gimmicks over beneficiaries. The last time you claimed savings in Medicare through the Inflation Reduction Act's drug price setting program, you used that $300 billion in savings to pay for Green New Deal policies such as green vehicle tax credits. How can you assure the new revenue will be used for Medicare solvency when your own budget also claims these same tax increases will be used for deficit reduction?
Mr. Chairman, what I can tell you is that the President is committed to make sure that he not only extends Medicare into the next generation, but he does it by protecting the benefits that current Medicare beneficiaries receive. And the beauty of this is that because he does it in a way that doesn't hurt middle-income Americans, we can make sure that as you continue to work, you're going to be ready to receive your Medicare ready and fully there to go for you. And so what I can say to you is that the President is the first President I know, and I sat at that dais for over 20 years, the first President who's actually proposed a real plan to deal with Medicare to keep it strong for the years to come.
So that leads to my next question, because he didn't address this issue in regards to Medicare. During the Biden administration's first 2 years, we have seen nearly $2 trillion in unpaid for reckless Democrat spending. And according to PAYGO law, this will result in more than $500 billion in cuts to Medicare over the next decade. To the detriment of seniors, your budget shows no plan to reverse these cuts. You simply ignore them and try to sweep them under the rug as if they're not happening. Why don't you account for these looming cuts in your budget, and what are you going to do to prevent them from taking place?
Mr. Chairman, we can try to go through numbers, but what I can tell you is that the President's budget actually reduces the deficit in the years to come. And what it does for Medicare is it preserves those benefits that we have become accustomed to seeing available to our family members, our parents, and our grandparents. And what I will tell you is this. The President made sure that he proposed a budget that not only would strengthen Medicare for the next generation, but at the same time, and the budget numbers show it, would be able to reduce the deficit long-term by substantial numbers into the hundreds of billions, if not trillions.
But the budget doesn't say anything about the $500 billion in looming cuts from PAYGO. Do you have anywhere in the budget that you would show that the President's going to make sure those cuts don't take an effect?
So I'll try to stay in my lane and speak to HHS budget elements and say to you that within Medicare, I can speak to you unequivocally that this budget protects every single benefit that the Medicare laws provide to seniors and those who are disabled. And it does so by making sure that moving forward into the next generation, those very benefits are there for them as well.
Last Tuesday, you received a letter from myself and all the Republicans on the Ways and Means Committee and Energy and Commerce Committee asking specific questions about proposed changes your department wants to make to the Medicare Advantage program. Your department is claiming a 1% increase in Medicare Advantage payments for 2024. This calculation includes what's called the risk score trend, basically a metric that's supposed to project insurance plans' coding behavior throughout the year to care for their beneficiaries. Do you agree that the risk score trend, of which CMS projects to be 3% for 2024, is a forward-looking metric and is not factored into a plan's base payment?
Mr. Chairman, today, after some 30 years, almost 30 years of managed care within the Medicare system, we have data that helps us be able to project forward. And the projections that we are making are based on data. And that data are showing us that in many cases that we have been overpaying those insurance companies that are within the Medicare system. We're simply trying to make sure that we keep money in Medicare for Medicare beneficiaries. And no one whether it's an insurance company or a provider, should make unreasonable profits at the expense of Medicare beneficiaries. And so we're just trying to make sure that we now use the data, the evidence that we have, to make sure that we move forward in the Medicare program, whether it's the fee-for-service program or the managed care program.
It's my understanding that this is a projected metric. Do you agree that your own agency, CMS, approves Medicare Advantage insurers' bids excluding this risk score trend?
Chairman, why don't you ask that question again? Now you're asking me to get into CMS's business, so I want to make sure I'm...
Yeah. Do you agree that your own agency, CMS, approves Medicare Advantage insurers' bids excluding this risk score trend?
So I'll try to answer best I can and certainly ask our administrator to respond more directly and precisely, but we make sure that we follow both the statutory prescriptions that we have and all the regulations that are in place for the managed care program within Medicare when it comes to how we put out the reimbursement rates for those insurance companies. And what we're finding is, of course, that we are overpaying in many cases, and now we're trying to make sure we get some of that money back. It's in the billions.
It's my understanding that CMS excludes this in their evaluation. So excluding this risk score trend, Medicare Advantage insurers will have to set their premiums based on an expected 2% decrease in payments compared with last year, correct?
We in our plan, we do not require Medicare Advantage plans to cut any Medicare services that are provided within the confines of the law of Medicare.
So, Mr. Secretary, it's basic math. 1 minus 3 is a negative number. We have heard from many concerned groups that this proposal may lead Medicare Advantage insurers to increase premiums or decrease certain benefits, potentially impacting seniors and their access to care. I urge you to provide a diligent response to our questions that we sent you. One last thing. HHS under President Trump established a hospital price transparency rule that went into effect on January 1st, 2021, requiring hospitals to post publicly the cost of various medical services they provide. Unfortunately, there are major concerns regarding hospitals' compliance with the rule and whether the data is truly helpful for patients. What is the Biden administration doing to ensure hospitals are abiding with not just the letter, but the intent of that rule so that patients have greater transparency and insight into the cost of the procedures before they receive care?
Excellent question, Mr. Chairman, because we're trying to make sure that we move forward that new law. I think there's still some 30% of providers who have not yet complied. We're trying to move quickly. Part of it, we have to recognize that these providers had never had to do that. All of them use different formulas to figure out what their cost structure would be. We're trying to get all of them to become more uniform, but that does not excuse for them not complying with the law. And so we're trying to be more aggressive in how we get them there. Hopefully it's with a carrot, but we've got the stick as well that you all provided us, and we will definitely try to do that. And look to you for some guidance as well, because we want to make sure that as we get all these providers to be transparent in their pricing, we do it without hurting the little guys who don't have the kind of wherewithal that the big guys do to really get in that stream of things. And by the way, on Medicare, managed care program, Medicare Advantage, so-called Medicare Advantage, Mr. Chairman, our proposal increases the amount of money that those insurance companies will get from last year. How anyone can claim that there is going to be a cut, I don't understand. The second thing is there is nothing that we are doing that would require any insurance company to cut any benefits to any American on Medicare. If they make those cuts, it's those insurance companies that are doing it, and it's on them, not on the laws or what we've done at CMS.
It's just a huge concern for 31 million Americans, and we're very concerned because
it should be.
Because many of these Americans are worried that they're going to have cuts, and the way that we add it up, it appears that there's going to be a minus 2% cut.
Well,
so
that's what happens when you have these deceptive commercials that are on TV, and I think it's unfair.
We need to, yeah. This will not be the last we discuss this topic.
Yes.
Thank you, Secretary.
Thank you, Mr. Chairman.
Recognize the gentleman from Massachusetts, Mr. Neal.
Thank you. Under President Biden and with your department's leadership, Mr. Secretary, we've seen an increase in the number of Americans with insurance coverage, a reduction in out-of-pocket costs, and lowering insurance and drug costs due to both strengthening and the growth of the Affordable Care Act. Our legislative agenda on the Democratic side, including the Inflation Reduction Act, is prevailing. Today, more than 40 million Americans owe their health coverage to the Affordable Care Act. That's how important this law is. Just last week, the other side tipped their hand on some of their health care ideas. More of the same, allowing insurers to discriminate against patients with pre-existing conditions, including diabetes, shifting costs onto patients, and promoting tax accounts that benefit the wealthy. All of this instead of bolstering a law that is not only widely popular, but also what consumers want and need. That agenda would raise health care costs for families across the country. On average, Americans with coverage through exchanges have saved $800 this year thanks to the Inflation Reduction Act, and the other side would put those savings on the line, as we noted in this committee just recently. We still haven't seen a Republican budget plan. They want us to get to work on balancing a budget, but they won't show us their plan. Make no mistake, their proposals will have a hard time under the magnifying glass in standing up. They simply will punish the sick by making them foot higher bills. If going after workers isn't enough, many of these positions will go after seniors. One of the first bills to repeal the life-changing drug pricing provisions of the Inflation Reduction Act, they would remove the power to negotiate drug prices for Medicare, eliminating the cap on out-of-pocket costs and insulin. Had the insulin cap been in effect in 2020, more than 1.5 million Americans would have saved $500 that year, including free vaccines that will save the average American $70 as beneficiaries. I think we can agree they will attack family budgets through their plans. Finally, Mr. Secretary, let me take a note for a moment, by the way, to congratulate North Carolina on expanding Medicaid and the Affordable Care Act. A reminder that every child in Massachusetts has health insurance. 97% of the adults in Massachusetts have health insurance because of the ACA, and it polls regularly in the high 70 percentiles. But finally, you and I have spoken a number of times, Mr. Secretary, about surprise billing. Mr. Brady and I, the former ranking member, we know precisely what we intended with the language and the words that we chose. We have not only prevailed in this committee, we have prevailed on the floor of the House, on the floor of the Senate, and now in subsequent in court cases. I hope that these implementation issues will be consistent with what this committee intended, and much of the confusion and expense has been a result of a department that is not fulfilling the wishes of what the committee intended here on this legislation. We need a commitment to indicate that we will continue to expeditiously air these issues and do precisely what this committee intended when we marked this legislation up. We saw it on both sides as a huge accomplishment. And if you might, in the last 14 seconds, Mr. Secretary.
Yeah, and I know we'll talk about this more, but first I have to say thank you to you, Mr. Brady, and many of your colleagues who pushed this, because at the end of the day, we still have work to do to make it work right, to your point. What we can guarantee you is that Americans, as consumers of that health care service, as the patients, are taken out of the food fight between the provider who gave the care and the insurance company has to pay it. The most important thing you did was to make sure that as that fight continues, it's not patients who have to pay the price.
Recognize the gentleman from Florida, Mr. Buchanan.
Welcome back, Mr. Secretary. It's great to see you.
Great to see you.
We did work on a lot of things together, so I appreciate that. I want to touch base on Alzheimer drugs. I'm in Florida. I've got the 5th oldest district in the country. So CMS decided they won't cover the new Alzheimer drugs. It just seems like every family's touched by this. To give someone an extra 6 months or a year, even though the drug's maybe not quite where it needs to be, is a big deal. But it basically, essentially put them out of reach for 6.5 million Americans with Alzheimer's. Just 2 weeks ago, however, the Department of Veterans Affairs announced they would cover the latest costs for veterans. Sadly, CMS is still blocking access to this. In fact, CMS refused to even consider the decision, even though the Alzheimer's Association is strongly supporting it. I've met with them. Given the VA decided to cover this drug, will you commit to working with CMS to try to reconsider that decision? Because it's devastating, I would tell you, to, I think, a lot of people across the country, but especially in Florida.
Congressman, there's nothing you said that I don't agree with. There isn't probably a one of us who hasn't gone through the circumstance where one of our loved ones, our parent or grandparent, is going through Alzheimer's or some form of dementia. I've gone through it. My wife has gone through it. It's devastating, especially if, like us, you're the one that's providing a lot of that care. And so, and I've said this to the folks, the advocates from the Alzheimer's Association, you keep pushing. You're doing everything right. And what I will tell you is that CMS is moving in a direction which I think will give a lot of Americans heart to believe that their loved one will have an opportunity to get
Let me get
coverage.
another question in at least, because we only got
Okay,
3.5
I apologize.
minutes. Also, I just want to touch base on the year 24 in terms of Medicare Advantage. They're looking at a cut, 2.3%. It'll negatively impact 31 million people that got Medicare. It's huge, over 50%, 55% of people have Medicaid, Medicare Advantage. And they're looking at raising the price from $540 to $830, which is over a 50% increase. It's huge because a lot of the seniors, that's all they have. It's very important. Is that something you can consider and look into as well?
So, Congressman, here I want to be really clear. We're not doing any of what you just said. I'm not sure where you got that information, but we are increasing the amount of reimbursement we're getting to these insurance companies. If these insurance companies are claiming that they're going to have to cut benefits, it's because they don't want to provide them, and they're more willing to take care of their profits over those
I'll get you
services.
the information to back up on that.
Please.
I led a letter with Chairman Smith, Energy and Commerce Chairwoman Rogers, and Health Subcommittee Chairman Guthrie. I'd like to submit it for the record, asking direct questions about the impact this will have on seniors and how CMS determines these rates.
Without objection.
Look forward to getting it.
And with that, I'll yield back.
Thank you.
Gentleman from Texas is recognized.
Thank you, Mr. Chairman, and thank you, Mr. Secretary, for your service. I think among the many positive provisions in the President's budget are those that are designed to strengthen Medicare. It's not enough to say we won't cut Medicare. It's taking the steps necessary to ensure that it's there not just for today's grandparents, but for tomorrow's grandchildren. I think further comment from you is in order about Medicare Advantage. I remember, as you do because you were on the committee, when people came forward and told us how much money Medicare Advantage was going to save Medicare. Instead, we find it to be one of the most profitable sections of the insurance business. I heard the suggestion 31 million Americans are concerned. I think it's rather a few hundred insurance executives that are concerned that getting $1,500 on average per Medicare beneficiary, paying that much more for Medicare Advantage than for traditional Medicare is just not enough for them. MedPAC, the independent agency that looks at these issues, has estimated that we spent about $27 billion in overpayment to Medicare Advantage this year alone. I've seen those misleading commercials you referred to, and I know our constituents are being bombarded with tales about all that's going to go wrong if the administration proposals are adopted. They're the same folks that get bombarded with one misleading advertisement and phone call after another trying to sell them on a policy that may well provide them lack of access to their physician at a time when they need it the most. Seeing what you have done to date, is it not correct that you're not cutting Medicare Advantage, you're not really getting back that $27 billion in overpayment, you're actually, under your proposal, increasing the payments that Medicare Advantage companies will get in the next year by 1%. They're just unhappy that the increase they're getting is not as big as the overly generous increases of the past.
Congressman, that's right. We are actually increasing the amount of payment that we're making to them from the previous year. And as my mother will ask me when she sees these commercials, and she'll call me and say, can you tell me if I'm in the right plan or not? I tell her, look, what would you expect from a commercial that's peddling a product to you? They want you to buy it, and so they try to pitch it to you in ways that will sell it. And unfortunately, once some of these seniors lock into some of these policies, they realize they're not getting what they thought.
Well, I hope that in addition to what you do in terms of payment, that we will continue to see vigorous examination of the false claims that are made to ensure that everyone who relies on Medicare Advantage and takes that approach gets what they are promised. Thank you very much. I yield back.
I now recognize Mr. Smith from Nebraska.
Thank you, Mr. Secretary, Mr. Chairman as well. Thank you, Mr. Secretary, for joining us today. I would like to start by calling your attention to a letter I sent to you on March 10th, a February 25th, 2023 article in the New York Times and a subsequent report by the Washington Post that have raised serious concerns about the Office of Refugee Resettlement at HHS. Everything about this situation, from unaccompanied children at the border to the lack of sponsor vetting to the ORR losing track of these children, I have to say is troubling. So I hope you will respond to my letter, hopefully by April 15th as requested, so we can ensure that HHS is able to address these issues. The COVID public health emergency is scheduled to expire on May 11th. I welcome this expiration. There are hundreds, though, of waivers, many of which have vastly benefited patients around the country, which immediately sunset with the PHE. These expirations have the potential to impact virtually every medical provider and patient, but would have a disproportionate impact, I believe, on rural and underserved areas like my home district in Nebraska. For example, it appears that without intervention, the following regulations will return to full force on May the 12th. The 96-hour and off-site provider telehealth conditions of participation for critical access hospitals, the 3-day hospital stay rule for skilled nursing facility admittance, and the long-term care hospital waiver of site neutrality in IPPS. Mr. Secretary, should we have the concern that the return to full enforcement of these regulations will have impact on patient access to care?
Congressman, absolutely. And we thank you for the extension to some of those telehealth opportunities that will expire at the end of 2024, but we need to do something permanently.
Okay, so I guess can we count on your support of efforts to make many of these provisions permanent that have proven to be effective, and especially for patients themselves?
We'll be there side by side with you as you try to negotiate the terms of that, because, again, most of this is baked in statute, and so we're going to have to make changes through Congress.
Okay, thank you. I appreciate that. Now, finally, earlier this year, CMMI released 3 new models targeting prescription drugs, and to date, CMMI tested more than 50 models, only 6 of which have delivered statistically significant savings, a less than 12% success rate. Not acceptable in many eyes. I've been concerned for years that CMMI often overextends itself by attempting to do too many things at once. And this leads to overlapping and counterproductive results, which can harm both patients and providers, while currently wasting Medicare's finite resources. CMMI Director Fowler even said, quote, "We need to move away from this spaghetti against the wall, see what flowers bloom approach," end quote. Can you perhaps explain how simultaneously launching 3 different models targeting the same problem is different than the failed scattershot approach of the past?
And Congressman, I answer this knowing that as a former member, I, like you and many others, would always ask CMMI to test certain things. CMMI is supposed to be our incubator, our place to test ideas, but on a very small scale. So if they don't work, we've not spent a ton of money. But if they do work, the return will be phenomenal. And what we want is to promote innovation. So CMMI is the place where we can tell the private sector, give us your best idea. We'll help seed it, and if it can go, great. And if it doesn't, no one, including the taxpayer, loses a whole lot. So I would want to work with you to make sure that we get good ideas coming forward to CMMI, but I would hate to do anything that stifles the innovation and competitiveness that CMMI promotes.
Thank you. I yield back.
Mr. Thompson from California is recognized.
Thank you, Mr. Chairman, and thank you, Mr. Secretary, for being here. And I just appreciate you pointing out the benefits of the ACA, everything from access to preventive health care, doing away with the pre-existing condition limitations. And remember, before we passed the ACA, being a woman was a pre-existing condition. Getting a handle on prescription drug costs, no more junk policies. There's countless examples of my district and everybody else's district of how people that we represent have benefited from this, and thank you for your ongoing support. I'd like to ask about 2 priorities of mine, mental health and telemedicine. I'm grateful that you and President Biden have made mental health a high priority, but I'm concerned that too much of our focus is on treating the symptoms of mental illness as opposed to understanding its underlying causes. There's not enough money in any president's budget to treat every mental health symptom. We need to get ahead of the curve, and that's why Mr. Kelly and I have legislation that will provide tax incentives for brain research. I've sent that bill to Treasury to get their comments, and I'd appreciate it if we could send it to you and get your team's comments on that as well.
Absolutely.
Thank you. And I'd also like to ask about telemedicine, and thank you, Mr. Smith, Nebraska Smith, for raising this issue. It's been a long-time priority of mine, and I think one of the few silver linings in the COVID cloud, as you know, that we passed my legislation to allow Medicare beneficiaries to access health care services via telehealth. And that was a real help to them, and it really provided a better means by which providers could treat their patients. And last year, we passed a 2-year extension of those telehealth flexibilities. Part of the reason we passed that extension was to give agencies, including HHS, the opportunity to study health utilization over the past several years, how it was used, where it can be approved, and how it's affected costs. I have legislation with Mr. Swigert, along with our colleagues on the Energy and Commerce Committee, which would make telehealth a permanent part of Medicare. That bill, by the way, was sponsored last year by over half of the U.S. Senate. So as the 2-year extension plays out, I'd like to know how you envision the role of telehealth in the future, particularly in Medicare programs. And is there anything specific that your agency is looking at to make sure that we have the best handle on this?
Congressman, I know we don't have much time, but what I'll tell you is that we've seen the dramatic results in behavioral health. We weren't sure what would happen with folks who needed mental health care services. We thought perhaps they needed to have that person-to-person contact with their physician and their healthcare provider. It turns out that one of the greatest gains was made in mental health, where because you could do this in the privacy of your home, you felt more comfortable coming forward and accessing mental health services. At the same time, we saw a dramatic drop in missed appointments because now you didn't have to worry about traveling there if you didn't have transportation. We hope that we can work with our states to figure out how we deal with the cross-state issues that are involved with licensing of medical practitioners.
And is it fair to say you're for making it permanent?
We are absolutely, it depends on where we're going, but yes, there's absolutely a need to continue some of these telehealth flexibilities.
Thank you. I yield back.
Recognize the gentleman from Pennsylvania, Mr. Kelly.
Thank you, Mr. Chairman. Mr. Becerra, good to see you again.
To see you.
You spent a little bit of time in between. I just wanted to ask you something because I've been in the private sector my whole life, and I'm trying to figure out how you put all these pieces together. You have 83,000 employees, is that right?
About there, yes.
That's a big payroll. That's
Yes.
a big payroll. So, and approximately 4,000 of these employees are based at the CMS at their Woodlawn, Maryland headquarters. So how many of these employees are working today in person, actually in person?
Congressman, the HHS workforce went back to full-time work from the get-go. We were able to use telehealth during COVID, and now that we're beyond that, we're able to continue the workforce at full-time. And you've heard some of the dramatic results of a workforce that has continued forward. Some have never left coming into the office or coming into work. Others are taking advantage of some of the flexibilities that we provide so they could come in on some days and work from a different site other days.
Yeah, well, I have a photo. This picture, well, you say these people are at work. This is last Monday, okay, March 20th. This is at 10:30 a.m. in the morning. It's a beautiful parking lot. There's everything on there except cars. I guess, I don't know how your people get to work, but this is your office building, and you're telling me they're working full-time. They must be working full-time from home or some other way of doing that. I just don't understand that. You know,
Congressman, that's
this
not
year,
my...
this year, no, Mr. Secretary, this is a picture. You've seen it before, and you know what it is.
Yeah.
And then we request another $18 million in rent compared to last year. So when you look at the people that fund all this stuff, and these are hardworking American taxpayers, I like the talk that goes back and forth about what we're going to do for sick people, how we're going to shore this thing up, how we're going to do this, how we're going to cover all this stuff. At the end of the day, there's only one person signing that check, and that is the taxpayer. So why should the American people be expected to pay rent for an office building that isn't even being used? There's so much waste in this government. There's so much fat in this government. It is impossible. I'm embarrassed to go back home and tell people this is the way it's supposed to work. This is not the way it's supposed to work. This is crazy stuff. Nobody would look at this as a business model and say, hey, yeah, good idea. Let's pay a lot of rent. Nobody has to be there, but we'll pay rent. Now, you said you're going to get the whole workforce back to work. They're actually going to show up in person in their buildings and actually work. And I'm not talking about being on these little things we've set up and all the little pictures show up and people get a chance to talk. I don't know. I think that they're so inefficient right now. Are you telling me, and I want to know this seriously, do you ever expect to be back fully at work, at their desks, in their buildings, doing the work for the American people?
Congressman, we are fully at work, full-time.
Well, this was a national holiday then, probably, right? This is March 20th.
You know, Congress, I don't even recognize that photo. That's not certainly a photo of my office building.
Oh, okay.
Maybe a parking lot of a building that HHS has employees in.
Yeah, well,
I doubt that you can say that that speaks to the work that's being
Well,
done.
I will tell you this. This is Woodlawn, Maryland, your headquarters. If this is your headquarters at 10:30 in the morning on a Monday morning on March 20th, there's something that doesn't match with what you're telling me. I don't want to keep grilling you on this because I'll tell you what, both you and I pay a portion of whatever it is that we earn to fund all these things. I just am appalled at the way this government works. There's so much fat. The things that we have to do, yes, do them. But you better learn how to work within a budget and make sense. I can't take this home and tell my people that I represent, you know what, listen, it may not make sense to you, but it doesn't have to. This is the way we run our government. This is your parking lot in Woodlawn, Maryland. That's where it took place. It did not take place someplace else.
But you cannot say that the folks that work in that Maryland site, if there is a site there, are not working.
I don't know. You know what? I would love to go sometime. I would even like to go to the IRS and see those people working at their desk, and I'd like to see your people working at their desk. 83,000 people getting a paycheck from the American taxpayers. And what we say is they'll work part-time. 30 hours a week is part-time. I would just say this government has a lot of people that are part-time. I think I yield back. Listen, I do appreciate your service because I like you personally. You know that. But I do, more than you, I like our taxpayers. And you're the guy in charge. It's a heavy lift. My God, 83,000 people.
They're working.
I know, I hear what you say. I'm just saying the pictures don't reveal that they're working, and I think the American people deserve an answer.
I'll bring
to
you
that.
some pictures next time.
Okay, very good. Thank you. I'll go here with you.
The gentleman from Connecticut is recognized, Mr. Larson.
Thank you, Mr. Chairman, and thank you, Secretary Becerra, for being here. It's great to have you back with the committee, and thank you for your continued work and support both while you were here and as Attorney General of the state of California, and now in your capacity as Secretary of HHS. Mr. Secretary, last year we passed the Inflation Reduction Act, and as you heard Ranking Member Neal run through a number of the things that were accomplished. I want to associate myself with his remarks, but as someone like yourself who's been a longtime advocate of lower drug prices through Medicare negotiation, we were pleased to see that the President's budget calls on Congress to build on what we did in the Inflation Reduction Act, which keeps money in seniors' pockets while also making Medicare more solvent. My question, and to give you a time to do this, can you walk us through your agency's progress in implementing the drug cost provisions in the Inflation Reduction Act, and tell us how each provision will continue to deliver for the American public?
Congressman Larson, and thank you for your efforts over the years on these issues as well. Well, today, those who are in need of insulin are getting it for $35 a month or less, and that's something that's saving most Americans several $100s for this year alone. Those same Americans on Medicare now can access a vaccine, whether for the flu, for COVID, for shingles. And I always hear about shingles because apparently that's a pretty expensive vaccine, $100, $200, free now. No out-of-pocket cost for folks on Medicare to access that. That's saving people quite a bit of money. On top of that, we made the announcement that come September, we will announce the first 10 drugs that will be part of that drug price negotiation that will begin. Though the companies that manufacture those drugs will go through the process then of negotiating for the best price for folks on Medicare. And we hope to continue that process because at the end of the day, this is about saving people money. Right now, Americans, as you know, are paying 2 or 3 times more for the same drugs that are being sold in other countries, and even if those drugs may have been manufactured here in the U.S.
And so this direct negotiation, seniors have long been anticipating this, et cetera. So it'll be in September that we'll hear. And how many drugs?
There will be 10 drugs, and then the next year it'll be 15 more. Then the year after that, we add more, and every year we get to add them. I think in your wisdom, you said, make sure you do it right for the first 10, and then let's keep going from there.
Thank you, Mr. Secretary. I greatly appreciate it. And with that, I'll yield back.
Gentleman from Arizona, Mr. Schweikert is recognized.
Thank you, Mr. Chairman. Mr. Secretary, this may sound odd, but I think you actually have one of the most interesting, if not one of the most difficult jobs in the world.
I concur.
But I also am constantly frustrated that we don't take your agency dramatically more seriously. And look, in the President's budget, you have new taxes. The President's budget has new taxes in there for shoring up part of Medicare Part A that equal, what, about 660 billion over a 10-year cycle. If all, and I'm not asking you to play budget with me, I'm just sort of setting up a question. But the math from 2022 basically said Medicare shortfall over 30 years with interest, so this is from 2 years ago, was over $80 trillion. So I'm elated, hey, you're going to talk about shoring up the Medicare Part A trust fund, but remember, the vast majority of Medicare spending is general fund. It turns out your agency, our obligation we made to seniors, is the primary, it's 3/4 of all the borrowing over the next 30 years. You are the epicenter of what in many ways is the greatest threat to our republic, and that's our debt. You know, whether it be my kids or someone's secure retirement. So there's some things that are not meant to be got you, but are there things we could do to help your folks on the innovation side be much more innovative, much more risk-taking, much more forward-viewing? We have a document that was working through your numbers saying 31% of all Medicare spending is diabetic-related. Okay. Could we actually do an all-in approach to stabilize pre-diabetic populations? Is it true that remember, there's a phase 1 that's just begun of a potential cure for diabetes? In a weird way, your agency, break us, or the innovation in your folks save us from a future that's just brutal, debt-wise. And I guess my rambling is more about what can I do, what can we as members do? Because I've gotten some really crappy responses sometimes from your innovation folks saying, we're looking at that, and then we never hear before. What can we do to make them almost techno-utopians, that we got to push the solution?
So, Congressman, let's see if I can give you a 2 or 3 different points, and you can build on them if you like. First, I go back to what I said earlier, because you hit it on the money. Why are we spending so much money on diabetes? Because so many of these cases of diabetes could have been prevented. And so rather than try to cure it, as my mom used to always say to me, mejor prevenir que remediar, better to prevent than to remediate. Why not try to prevent it? And that's my whole opening statement was about how moving from an illness care system, which is what you're pointing out is deficient, to a wellness care system.
But what I beg of you is in your opening statement, you didn't actually, you said wellness care, but you didn't say we need to fix nutrition support. The way we do it isn't working. There's actually things we can do to help people manage their blood glucose. You've seen even the discussion, something I can wear on my wrist that may tell me what my blood glucose is. We now have what, and I'm going to screw up GPL-1 inhibitors and the variety of those that are off patent. The fact of the matter that there may be a stem cell therapy coming. If it's the single biggest driver of debt in our country, where's your all-in approach? Where's the the maniacal fixation that we're going to take this on, because it's not partisan, it's not Republican, Democrat, it's moral. And with that, I yield back.
Mr. Blumenauer from Oregon is recognized.
Thank you, Mr. Chairman. Mr. Secretary, welcome back. I must say you look increasingly distinguished.
More like you, huh?
Well, not that distinguished. Thank you for joining us. I want to thank you for the work that the department has done working with the state of Oregon and I think Massachusetts, dealing with innovative efforts in terms of the waiver, being able to focus on social determinants of health that actually help people with things like nutrition and housing that will lower costs. I appreciate the creativity and look forward to working with you and the department to realize the benefit of those. I would, as you know, be remiss if I didn't mention one of the topics that we've discussed.
I see the chart.
In the last 30 years, we've gone from a country where there was no legal state, either medical or adult use, and in that period of time, we now have 37 states where at least some form of cannabis is legal. 21 states, it's fully legal. The American public overwhelmingly supports it, and yet the federal government is hopelessly out of step. I welcome the President's call to do a reappraisal of how we characterize this so we can have the federal government catch up with where the American people are as it deals with the reality of cannabis, and I look forward to working with you. I appreciate your notion of the prescription drug reform. The American senior, primarily, does not have to pay 2, 3, 4, 5 times the world price for prescription drugs in order to underwrite medical research for the rest of the world. I'm not certain that the pharmaceutical companies would hold us hostage, but I think it's too steep a price. American consumers, especially seniors, should not be held hostage, and I appreciate the work you're doing implementing this bidding effort. Let me just touch on one other area. We have talked about some of the concerns we have, for example, in terms of for-profit hospice, where we found shadow companies that have buildings, get money, but have nobody that they're serving. I noticed that you have $5.2 billion for program integrity. Can you talk about what that's going to enable us to do to make sure the taxpayer is getting full value?
Congressman, we know that during COVID, we had more people die in nursing homes than was acceptable. We know that in too many cases, people are profiting off of saying that they're caring for some of our most precious loved ones who need help. And we want to make sure we get to go in and do some oversight. We want to make sure Sunshine will be a good disinfectant when it comes to caring for our loved ones. And so we hope you will consider truly consider our request for more money so we can do the oversight. I speak as a former Attorney General who worked hard to go after some of this abuse against elderly Americans, and we're going to do as much as we can.
I think you will find bipartisan support on this committee to deal with the integrity of the hospice program so we're not cheating patients or the government.
Amen.
I yield back.
Gentleman from Illinois, Mr. LaHood, is recognized.
Thank you, Mr. Chairman. Mr. Secretary, welcome. Mr. Secretary, last year, you and I spoke about my concerns with the response times from HHS in responding to congressional letters. And unfortunately, I can't say that that has improved today. Just this afternoon, I received a letter that I sent asking for a response 5 months ago. And I don't find it a coincidence that I received a response today when you're appearing before this committee. As we all know, Mr. Secretary, workforce challenges are a major concern across industries, but particularly within the healthcare community. This is why last Congress I introduced a bipartisan bill called the TRAIN Act, along with Representative Blunt Rochester of Delaware, which became law at the end of last year. This bill addressed a nursing workforce issue caused by CMS in which they began to recoup funds given to hospital-based nursing schools based on a CMS error. Taking funds away from nursing schools during a pandemic and workforce crisis certainly seemed misguided to me,
And so we worked in a bipartisan way to address this issue to prevent the recoupment. However, we passed that law. It now appears that CMS is going against congressional intent in their recent transmittal notice for implementation of the bill. CMS has created a complicated formula to describe how these impacted schools would get their money back. The formula would not fully stop recoupment and return the funds, but instead only provide between 29 and 76% of the funds owed back to these schools. In our bill, CMS was directed to return the funds that were taken from each school. It is beyond frustrating, Mr. Secretary, that something so clear in the statute could be implemented in this way. These hospital-based nursing schools, of which I have several in my district, provide hands-on education, allowing more nurses to enter the workforce and serve rural and underserved communities. Before our bill could become law, many of these schools closed, and now CMS continues, Mr. Secretary, to impact the remaining schools by only returning a portion of the funds they are owed. This is simply unacceptable, and I would like your commitment, Mr. Secretary, to look into the creation of this formula and respond to me in writing on why CMS chose to go against our directive and the clear congressional intent on this issue.
Congressman, let me do this. I will call, why don't we, after this hearing, I will try to reach out to you and have specific conversation. You let me know who from CMS you want to have on that conversation, and then let's follow up so we can make sure that we're following the intent the way it should be.
Thank you. Mr. Secretary, in my remaining time here, I would also like to comment briefly on my concerns with CMS determination on coverage with evidence development, CED requirements for Alzheimer's treatments. In February, I, along with 74 of my colleagues, wrote to you with our concerns on how CMS continues to address the CED process, particularly as it impacts constituents and their families and caregivers in my district who are unable to participate in academic clinical trials. I have serious concerns about how CMS is making decisions on this issue, and I await your timely response to our letter sent to you on February 6th. And I would just say that doesn't mean waiting 5 months from now. You mentioned earlier in Mr. Buchanan's comments that you told the advocates to keep pushing. There is immense frustration that my constituents and many people across the country cannot participate in these academic clinical trials. If you could respond to that.
Yeah, and we're trying to make sure that we do provide for a diversity of participation in these trials. Oftentimes we find that folks in rural America don't get to participate in trials. Folks in some urban poor areas of America don't get asked to participate. So we're trying to make sure that those who will participate include those from all parts of our country. We can do everything we can within the clinical trials, but at the end of the day, it's the investigators who have to make sure that they're pursuing folks to participate. But I'm absolutely prepared to work with you and others who are interested in this subject to make sure that where there's a clinical trial, that everyone has an opportunity to participate.
Thank you.
Gentleman from New Jersey is recognized.
Welcome back, Mr. Secretary. Thanks to the work of the Biden team, done an outstanding job. Americans emerged from the pandemic with the best economy in decades. The pandemic opened our eyes to the titanic need of skilled nursing. So I welcome the President's bold goal to remake our nation's 15,000 nursing homes. And I'm damn angry when I look at the results. This is a $130 billion industry. Wall Street's control over nursing homes grows with risks and abuses. Problems in our nursing homes have been ignored for too long. We need transparency for tax dollars going into big companies, and we must hold bad actors accountable when they provide substandard care for our seniors. A lot of statistics come out of these last 2.5 years, three years. I'm not going to go into too many statistics that I've done that before. Private equity firms, they're having a song and a dance. And you wonder why so many nursing homes are closing. You can't provide service unless you pay the help. You cannot provide service if the help is not up to the job. You got to pay for that. You get what you pay for. And private equity gets what they pay for. So we need transparency. 1 year into the White House initiative, what has this administration done to increase transparency of ownership so we could figure out who owns the darn place and management of our skilled nursing facilities? What's happened in 1 year?
Congressman,
Tell
first,
me that in 2 sentences.
first, thank you for your advocacy in this area. We have, for the first time, as far as I can remember, required the disclosure of ownership interest in these facilities, because we know that a shell game is often played with regard to who actually handles them. And probably something which you didn't quite say as explicitly is that oftentimes when ownership goes into the hands of a Wall Street firm, they're in there for the money, and so what they do is they extract assets and they oftentimes leave a shell. And the folks who are needing care are the ones who suffer as a result of having less than ideal services. We're also moving forward on the idea of having minimum staffing levels so that regardless of who purchases that facility, you can't go below a certain level.
Excuse me, Mr. Secretary. You've been looking at that for years. Your administration, the previous administration, the administration before that, the administration before that. What have you done? Want me to give you a list in New Jersey?
I can't speak for the previous administration, but I can tell you we're in the process of coming out with the rule that will require minimum staffing levels. That's more than I've seen any administration do.
And you're going to work this out with the equity firms?
We don't need to work that out with any equity firm. We get to do that based on a rule that's based on the authorities you gave us.
To your health.
Thank
I
you.
yield.
The gentleman from Ohio is recognized.
Thank you, Mr. Chairman. You go, Bill. I'm deeply concerned, Mr. Secretary, with the state of health services and human services in our country. I continue to hear from providers across the country, which I was one for 3 decades. They're closing their doors, walking away from providing care to patients every day because of the challenges that have come from this administration and because of some of your decisions, sir. Physicians are the ones that continue to show up to the front lines and make sure that patients receive the care that they need. Doctors are the ones who provide the health and human services to patients across this country. And if this pattern continues, there won't be enough doctors left to take care of patients across America. Your budget grows, you treat no one, you're a lawyer, and you ask providers to do more with less until they close their doors. Congress spent years negotiating a solution to solve surprise billing and do it in a balanced fashion. And yes, we took patients out of it. That we did. Congress passed the No Surprises Act to protect patients, create a balanced process. The president signed it into law. You ignored that. And we created a bill that created incentive for doctors to want to be in network and for insurance companies to want doctors in network. But you decided to implement the law in a manner that unfairly tips the scale in favor of insurers by placing undue weight on the qualified payment amount, which was just one component of arbitration and did not have weight over any others. You directly defied the law as written, and it's interesting, considering that you're a lawyer, that you would violate the law. And your illegal actions have led to a backlog of claims, and you called the claims recently to be frivolous. Well, you asked the patients that got the care if it's frivolous. And you asked the doctors, they have to pay their staff and their salaries and to stay open and to be in the black. You asked them if it's frivolous. You said patients aren't affected. They are affected. Doctors retire or they quit taking call. You come in that ambulance and guess what? There's no doctor on call because of the way you have implemented the No Surprises Act. You. So you're directly harming patients, actually. Doctors and hospitals need to be in the black to keep their doors open, to continue to provide a service, and they can't pay their help if they don't. What this says to me is you clearly don't value the work of physicians and surgeons and what they do for those in need, and without them, we have no health system at all. Mr. Secretary, will you implement the No Surprises Act as written in statute and not stray from the letter of the law as you have continued to do, as you have been informed that you have done by the courts, and maybe get out of the courtroom and into the emergency room and the operating room where HHS belongs?
Congressman, I respect especially the passion with which you speak to the subject. And so what I will tell you is where we've gotten guidance from the courts, we have followed it. We will try to do the best we can. If you were one of those who helped pass the law, I thank you. You probably remember when that was being discussed, I think at that point people thought 10, maybe 20,000 disputes would be sent for this independent dispute resolution process. In the first 8 months, 164,000 claims were filed.
But you're responsible for that, sir. The way you have implemented the law has driven this. You took away the fair process.
Congressman, there's nothing
so of
that
course
we
they
did.
want to go to arbitration.
Congressman, there's nothing that we
You
did.
called it frivolous, which is an insult to every provider out there.
I'm not calling it. It's the
I yield back.
arbitrators. The arbitrators are the ones that are saying that those were frivolous claims.
The gentleman from Illinois, Mr. Davis, is recognized.
Thank you, Mr. Chairman. Mr. Chairman, I ask unanimous consent to submit for the record a statement describing the accessibility of imported e-cigarettes and vaping material to young people in our country.
Without objection, so ordered.
Thank you, Mr. Secretary, for your work and the outstanding work of members of your staff. Medicare physicians' pay and its impact on patient access to care remains a major issue for many of my constituents. In fact, adjusted for inflation, in practice costs, Medicare physicians' pay actually declined 26% from 2001 to 2023, or by 1.8% per year on average. Nonpartisan government stakeholders are recognizing the damage and impact these payment cuts are having on patients' access to care. The 2021 Medicare Trustees Report states that absent a change in the delivery system or level of update by subsequent legislation, the trustees expect access to Medicare participating physicians to become a significant issue in the long term. To help address this growing problem, physicians are pushing for an annual Medicare payment update tied to inflation as measured by the Medicare Economic Index, the MEI. Even the March 2023 MedPAC report to Congress includes recommendations that Congress increase the 2024 Medicare physician payment rate above current law with an inflation-based payment. Mr. Secretary, could you share with us some of the administration's thinking relative to Medicare payments to physicians?
Absolutely, Congressman. And as you know, the President declared emphatically during the State of the Union that not only was he going to protect Medicare for today's seniors and Americans with disabilities who receive Medicare, but he was going to protect it for the next generation as well. And so his budget makes sure that Medicare not only remains strong, but it continues to offer benefits that under traditional Medicare fee-for-service or under managed care Medicare, either way, Americans receive their services. And that's why the proposal that we've put forward when it comes to reimbursement to providers continues to increase the amount that they will receive. The amount that we're proposing in this year's proposal is greater than the amount that we had proposed last year. And of course, we protect all Medicare benefits. We don't cut any benefits. We continue to preserve access to those same benefits that all Americans have become accustomed to having under Medicare.
Thank you very much, and I'm sure that the thousands of Medicare physicians, as well as their millions of patients, will be delighted to hear this answer. Thank you so much. Thank you, Mr. Chairman. Now yield back.
Gentleman from Georgia, Mr. Ferguson, is recognized.
Thank you, Mr. Chairman. Thank you, Mr. Secretary, for being here. A couple of items here. First of all, one of the things I'm very concerned about is antimicrobial resistance. We have not been doing a great job in this country of developing the next generation of antibiotics to fight these resistant infections. It's cost the system almost $5 billion a year, and and really probably somewhere around 36,000 people a year die because of this. We have a system failure here. It's a failure of the marketplace, and there's some very specific reasons. Do you think congressional action is needed to correct this, to prepare ourselves for the next pandemic, and to address the immediate cost to the system?
Congressman, first I have to say hallelujah for asking that question, because nobody asks about antimicrobial resistance. It is absolutely essential, and absolutely Congress needs to act, because we have to figure out a way to get the market to want to invent some of these new life-saving treatments.
Good. I look forward to working with you on that.
Can I just add real quickly that internationally we're trying to take this on as well. And so there's a lot of interest internationally to deal with antimicrobial resistance.
We just want to make sure that we lead
Absolutely.
in America. So with that, listen, you have touched on the Medicare Advantage issues. Again, I just don't share your position on that. And I want to say this. You made a comment to my colleague here from Ohio, Dr. Winstrip, that you were trying to implement the surprise billing law the way we intended it, and I'll simply say that trying is nothing more than failing slowly. Either you're going to do it or you're not, and I would encourage you to do it. So don't fail slowly. Just get it done the way Congress intended for that, and the way that this committee intended for you to implement that and to make the changes. Next, a couple of series of questions here. Over the past decade and a half or so, about the past decade and a half, has there been any sector of the healthcare environment that has grown at a slower rate than inflation?
Any sector of the
any sector in our healthcare economy that's grown slower than inflation?
We'd probably have to crack our heads together to see if we could find one.
You'll get a split in your skull. You'll have to crack your head so hard, so many times on that. Have there been an increase or decrease in premiums in the past decade and a half?
Well, here actually there's some good news. If I take you on the Affordable Care website, you can find a premium today for $10 or less a month.
Not the cost of the individual, but the overall cost of the premium, including the subsidies that have to be paid to drive that cost lower.
Okay, but we still have to take a look, because what
The
people are going to...
The answer is, I don't think you're going to find many folks that are saying that their healthcare premiums are going down.
But for Americans, the cost has gone down.
Really?
Yeah.
In what state?
Pretty much every state that has access to the Affordable Care Act.
You're going to tell us that the healthcare premiums in the state of Georgia are lower now than they were a decade and a half ago?
Absolutely, sir. Absolutely. When you can find a premium at $10 a month or less...
No. Not to the individual. I'm talking about the overall cost to the system.
I get where you're going, but what I'm saying to you is Americans...
Well, I'm getting where I'm going because we're spending entirely too much money. We've got an inefficient system. Reclaiming my time, a couple other quick questions. Are there more rural hospitals in America today or fewer? But more or less. They're fewer. I'll answer it for you. At least in my district. Are Americans healthier today than they were in 2010? And do we have more solo practitioners or more vertically integrated healthcare systems where an insurance company owns a PBM, that owns a pharmacy, that owns a healthcare system?
Mr. Chairman.
So my point here is that how you judge success of government-run healthcare and how we do are maybe two different things. With that, Mr. Chairman, I'll yield back.
Thank you. The representative from California is recognized, Ms. Sanchez.
Thank you, Mr. Chairman, and thank you, Mr. Secretary, for your testimony today. My colleagues and I worked tirelessly to pass the Inflation Reduction Act and to lower drug costs under Medicare. And these critical policies are saving beneficiaries an average of $800 per person per year. I call that progress. I'm also pleased to see that the administration is building on this work in the last Congress to extend ACA premium tax credits, as well as put more money in Medicare beneficiaries' pockets by capping out-of-pocket drug costs. I also think it's important to highlight your plan to close the Medicaid coverage gap, particularly as we see millions of Californians currently go through the redetermination process as the PHE comes to an end. These are the types of investments that we must continue to make in order to meaningfully reduce the costs weighing heaviest on working families and to help close those health care disparities. The HHS budget also includes expanded funding for long-term care through Medicaid home and community-based services. I want to bring your attention to that because studies have predicted that the number of seniors over the age of 85 who will need personal care due to fragility of aging and other disabilities will quadruple between now and 2040. Now, these are folks that don't need 24-hour medical care, but they do need assistance with everyday living tasks like eating, bathing, cleaning. Seniors with dementia in particular need these, and these tasks often fall on the shoulders of working families, and these tasks are often uncompensated. I have experience in this. I've been extremely fortunate to share caregiving responsibilities with my siblings for both of my parents, but I know firsthand how difficult it is to balance being a working mom and a caregiver, even when you have the means to do so. An average year of long-term care costs over $70,000, and most seniors' entire life savings are a little more than double than that. And Latino and African American households have significantly less in retirement savings than the average household. For example, half of elderly Latinos rely on Social Security as their sole source of retirement income. And Medicare, Medicare Advantage, Medigap, none of those insurers cover long-term supportive care. The only option for those who can afford assisted living facilities, costly private long-term insurance plans, or if they qualify for Medicaid. So, Mr. Secretary, I want to know, what is the department doing to address the predicted rise in long-term care needs, and how would you suggest financing such a system that does not solely rely on Medicaid?
Congressman, first, thank you for your commitment to this particular subject. Secondly, I mentioned the work that we're doing to try to improve the services at existing facilities, whether it's a nursing home facility or providing hospice care. We are, in this budget, providing for $150 billion in Medicaid home and community-based services because we know of the need to increase access to that long-term care. We're doing everything we can to do more inspection of facilities because we know that there have been a number of complaints and the need to make sure that there's transparency in the services that are provided. And we're doing as much as we can to try to increase the ability of states to do some of those inspections themselves and do the complaint surveys response themselves as well. So we have an investment of about $500 million, a little bit more than $500 million in the discretionary monies to help those states do those survey and certification programs.
I thank you for your work on that and for your presence today, and I yield back.
Gentleman from Kansas, Mr. Estes, is recognized.
Well, thank you, Mr. Chairman, and thank you, Mr. Secretary, for being here today. When I comb through the President's budget that adds $17 trillion to the deficit over the next 10 years, I see much of the failed policies that have caused record inflation over the last 2 years, and it's hurting Kansas families. In fact, a surgery center in Wichita told me that this year more patients are delaying surgery because they simply do have to make a choice between having a procedure or putting food on the table. Secretary Becerra, over the last 2 years, I've heard from numerous doctors in my district and the state that have indicated that participation in Medicare is becoming untenable due to the instability of reimbursement year after year. This means patient access is in jeopardy across the country, including my home state of Kansas, and particularly in rural areas. I've got a couple questions that maybe be yes or no, but do you recognize the instability of the physician fee schedule over the past 2 years as disproportionately appropriated patients, particularly rural ones, and particularly in specialty care?
Congressman, I think we all, and I remember being a member of Congress as well, the challenge that we have in trying to make sure that we're adequately reimbursing providers has always been there. It's something that we always have to address, and you have to address.
And will you help work with us and commit to helping evaluate the impact on rural access in order to, before you make future reimbursement changes?
Absolutely.
I also am concerned a little bit, particularly about changes made under the REMs for mifepristone. Under your direction, the REMs have been changed so that a woman no longer needs to see her physician in person in order to receive this harmful drug. But 1 in 5 women who take this drug need medical intervention following its use. That's 1 in 5. Your own FDA said that women shouldn't take it if they have an ectopic pregnancy. And FDA explains that if an ectopic pregnancy is not identified and removed, it can rupture and cause abdominal bleeding that can kill the pregnant woman. Ectopic pregnancies can only be ruled out by a healthcare provider using blood tests and an ultrasound. And the FDA has further warnings for women if they have problems with their adrenal glands or if they're taking certain medications. This critical information is given by healthcare providers with access to their medical history. Do you think the new REMS for this drug put women in danger?
Congressman, FDA puts out those REMS after reviewing all the science and the evidence that's out there. Mifepristone has been available for more than 20 years. It's been proven to be, as FDA has to show, it to be a safe and effective drug. And now they're moving forward based on several years of evidence, and especially during COVID, where they found that it could be prescribed safely and effectively without having to have the in-person visit by the patient in order to get access to the drug.
I'm just concerned that 1 in 5 need additional care afterwards. That has no bearing on that, but it's caused by that, and as well as the ectopic pregnancies. How do you plan to help make sure that they're checked for an ectopic pregnancy before this drug's dispensed to them?
Yeah, and I would need to check those numbers. I've not heard those numbers that you've recited. And I know from, I hear from my wife, who's a high-risk OBGYN all the time about this. This is a drug that has proven itself over the course of time. You don't just get access to it because you want it. You still have to get it prescribed. And so your your physician, your medical provider would still have to prescribe it. And so those kinds of areas where you need to have safeguards are still in place. It's just that the in-person requirement that a woman go to a particular spot to get that prescription drug would be removed.
Mr. Chairman, I yield back.
Gentleman from Pennsylvania, Mr. Smucker, is recognized.
Thank you, Mr. Chairman. Good afternoon, Secretary. The Work and Welfare Subcommittee is having a hearing tomorrow looking at strengthening TANF work requirements, and I'm sure you know that only 6 states have a 50% TANF work participation rate requirement, and 34 states have a 0% requirement. How is HHS making sure that states are being held accountable and implementing TANF work requirements?
Congressman, that's a great question, and I hope we can actually work on some of this because we're trying to work with the states to get more information. We all heard about the situation in Mississippi where a lot of TANF dollars were misused, and that was as a result of state officials not keeping watch of the money. We would love to work with you to make sure that our work to do oversight continues forward, the program integrity work that we do, but we certainly use your help.
So you agree that it is a problem we need to address and we can work together on that?
Well, when state officials divert dollars that are meant for needy families, that is absolutely a problem.
I'm talking specifically about the work requirements.
We can absolutely talk to you about any number of issues, including work requirements, but what we want to do is make sure that we're getting dollars to the families that are needy that qualify for those funds.
Thank you. I look forward to talking with you about it. As you know, as a hospital insurance trust fund trustee, the trustees currently estimate that Medicare Part A will go insolvent in 2028, at which point the program will only be able to pay 90% of benefits, meaning seniors will face a 10% cut in benefits. Is that right?
What I can tell you is that the President's budget addresses that to make sure that no senior, no person with disabilities would face any change in their benefits.
Let's talk about that because I do appreciate that there are some proposals in the budget to extend the solvency because I mean, that certainly is a goal shared by Republicans and Democrats. So I do hope that we can work together in a bipartisan fashion. However, I do have trouble seeing how the math adds up in some of the President's proposal. And a basic question, I think we'll agree on this, if the government raises taxes by $100 and then spends that $100, it's a zero impact on the deficit, correct?
Are you speaking about the Medicare program?
If the government raises taxes by 100 and then spends 100, what's the net impact on the deficit?
But if you're going to relate that to Medicare, then I want to make sure we qualify.
It was a basic question.
Well, if you're not speaking about Medicare and the President's budget, then I can answer that question because I don't want you to then say that I've said that the President will not strengthen Medicare.
It was a basic question, but is it true that the President's budget counts savings from potential drug pricing reforms towards both deficit reduction and then also injecting funds into the Hospital Insurance Trust Fund?
The President's budget, because it reduces deficits over the course of the next 10 years, will be good for America and our economy. At the same time, the President's budget will strengthen the Medicare program without cutting any benefits.
But it really sounds like a budget gimmick. when you're counting both the same cuts as deficit reduction and also injecting funds into the trust fund?
Well, the Congressional Budget Office, which is your scorekeeper, also shows that the president's budget will save us money.
Is it true that the president's budget increases taxes on small businesses by $650 billion?
So the president said that no one who earns less than $400,000, and if you're a small business person, at the end of the day,
the budget does increase taxes by $650 billion. Will those new taxes be used to pay for Medicare solvency?
Well, and those are taxes on corporations and the wealthiest individuals. But again, anyone earning less than $400,000, whether through your small business or through your employment, will not pay any increased taxes.
It's the double counting of the same funds that makes no sense. And Mr. Chairman, I'd like to enter into the record a budget model from Penn Wharton that their analysis points this out, the double counting and the budget gimmicks that the plan employs. So I'd like to submit that into the record if I could.
Without objection, so ordered.
Thank you.
Gentleman from New York is recognized.
Thank you, Mr. Chairman. Thank you, Mr. Secretary, for being here. In New York, every single hospital is reporting significant nursing shortages that they cannot fill. Over the last 3 years, contract labor has increased nationally over 250% and significantly in New York State as well. So many nurses across the country have left hospital-based positions and have gone to these traveling staffing agencies. It's understandable because the work is better, the scheduling is more flexible, but these agencies charge hospitals a significant markup to employ their nurses, leading some hospitals to accuse them of price gouging. The federal government pays a lot for health care, probably $1.6 trillion every year for Medicare, Medicaid, tax treatment, VA. It's a lot of money, but it's a lot of leverage. Is your agency aware of this problem, and are there efforts to address the shortage in a legitimate way without profiting significantly these agencies that employ traveling nurses?
Congressman, thank you for the question. And just as the state of New York is suffering through a workforce shortage, so are, I know, my state of California, and I suspect every member at this dais would say the same thing. We are making investments, and this budget does make investments that help expand workforce. It also helps provide states with the opportunity to train more people, whether nurses, doctors, child care workers. We want to increase the size of the workforce. One of the things that would help us increase the size of the workforce is if we get more women back into the workforce. We know that it's been very difficult. If you can't find child care, sometimes it keeps you from being able to go to work, whether you're the father or the mother. But principally, we know mothers have that prime responsibility more often than fathers do. And so we are working where we can. We did a grant proposal. That was, I think, last year, $103 million, where we put it out, and the recipients of the grant, we didn't put a lot of restrictions on it. What we said is, we want you to use it to try to retain some of your workforce, increase your workforce, or uptrain your workforce. And what we're trying to do is help keep folks in the healthcare profession.
Thank you, and I yield back.
The chair recognizes the gentleman from Oklahoma.
Thank you, Madam Chair. Mr. Secretary, thank you for being here today. My time is short, so let me be real quick here. 2 years ago, during your first budget hearing, you responded to one of my questions by saying that as Secretary of HHS, you are in the business of creating more jobs and getting people the health care they need, end quote. As you know, our current system is complex, unaffordable for small businesses to offer health care. Do you support the previous administration's policy to allow small businesses to cover the premiums of their employees through individual coverage health reimbursement accounts, also known as ICHRAs?
Congressman, I want to make sure, if you're talking about plans that would violate the Affordable Care Act and provide less benefits, if they're what we call these junk plans or skinny plans, we do not support those.
But so you're saying that based on your website on October 17, 2019, you said you're willing to support plans that are not junk plans.
Correct. Plans that offer real benefits. They may have a low payment, But the reason they have a low payment is because when you really need to use them, they offer you very little coverage for the services you will use, and you are stuck with the bill for the high coverage of those particular benefits.
So just so I'm clear, and you and I are clear, you're willing to work with us on ICRAs as long as they're not so-called junk plans?
Willing to work with you on any plans, whatever the idea is, because you are entitled to that work effort from our folks at the agency.
I think that's a yes. Mr. Secretary.
That's a yes. That's a yes.
Mr. Secretary, since the Bipartisan Orphan Drug Act was enacted into law 40 years ago, rare disease and cancer patients have benefited from the development of over 600 new treatments. This is tremendous achievement, though there's more work to be done. More than 30 million Americans across this country are living with a rare disease or disorder, and too many patients living with rare diseases and cancer still have no treatments available to them. Some of you may have family members with a rare disease, so you know the pain they face every day and the hope they have in spite of everything. I have a sister who passed away from spina bifida and another sister and her daughter living with spina bifida. Unfortunately, the Democrats' so-called Inflation Reduction Act threatens the continued success of the Orphan Drug Act. Specifically, it does not protect therapies that treat 2 or more orphan diseases from the law's price-setting scheme. As a result, we already know of 2 companies that have cited the IRA as a reason not to continue rare disease drug development. It's sad this budget proposes to expand those harmful policies further. Mr. Secretary, will you commit to doing what you can via guidance and rulemaking to ensure that the pipeline of life-altering therapies continue for patients living with rare diseases and cancers?
Congressman, we will absolutely do what we can to make sure that some of those orphan drugs are still available, because otherwise many of those folks would have no hope.
Mr. Chairman, I think that's a yes, and I appreciate it again that you're working with us on these issues, because there are problems that we need to work together on that have been fallen through loopholes and have been subject to concern based on what's coming out of the recent policies from the administration. So I appreciate you working with us, and I yield back.
Thank you. I now yield to myself. Thank you, Ranking Member Neal, and thank you, Secretary Becerra, for being here today. One of my biggest concerns about the United States healthcare is the current workforce shortage that we're all facing around the country. This shortage is particularly concerning in rural communities where hospitals are closing at higher rates than anywhere else in the country. While inflation caused by the Biden administration's out-of-control spending is partly to blame for hospitals struggling, a dwindling workforce is often also cited as one of the biggest problems for rural hospitals. One policy which contributed to this shrinking healthcare workforce was a vaccine mandate for the healthcare workers, which was put in place by the Biden administration. The Centers for Medicare and Medicaid Services gave hospitals an ultimatum: force your entire staff to get vaccinated, or no Medicaid services, where they will no longer participate in Medicare or Medicaid programs. In rural America, where a disproportionate share of patients are enrolled in Medicare and Medicaid, this gave hospitals an impossible choice. Your agency forced healthcare workers that did not want to get a vaccine out of the workforce. Secretary Becerra, on September 18th of last year, President Biden declared that the pandemic was over. The administration has also announced they plan to end the public health emergency on May 11th of this year. Can you please explain to me why this administration intends to keep the CMS vaccine mandate in effect until November of '24, especially when we know this policy is contributing to the workforce shortage?
Congresswoman, let me see if I can address your question straight on. COVID's still with us. It is not what it was 3 years ago, but today 200 to 300 Americans will likely die from COVID. It is still something we have to take into account and protect against. It is worse, and you will remember those days when you couldn't even walk into a hospital to visit your relative who was sick with COVID because you could become infected as well. We have to make sure we're protecting each other.
Well,
And certainly healthcare workers have to be protected against COVID, and we have to make sure we're protected against healthcare workers who are treating COVID-infected patients. And it would be irreconcilable to say that a healthcare worker who is around COVID should not be vaccinated, to make sure that he or she is not inadvertently passing COVID on to people who are not yet
Well,
infected.
you've just repeated that, basically. I'd like to now turn to something that will help bolster our healthcare workforce. In 2020, Congress took the historic step of adding 1,000 new graduate medical education slots to train additional physicians for the first time ever. Multiple hospitals in my district utilized the GME program, and I was so encouraged when Congress put guardrails in to ensure that the slots were distributed to rural areas that face acute provider shortages. Can you imagine my dismay when I saw recently that nearly 20% of the GME slots distributed around went to New York State alone? Can you commit to the committee that the next round of distribution will better prioritize rural areas?
Absolutely, Congresswoman. We will work with you because I have also fretted over the, when I was a member of Congress, I raised this issue of GME. And one of the issues, and perhaps for those of you who are in rural parts of the country, it is nearly impossible to get any of these GME slots because rarely do you find many of the medical schools located in rural America. And so we have to figure out a way to get some of these training slots because oftentimes where you train is where you end up living and practicing. And so we need to make sure we're directing some of these future doctors to communities like rural America where there's a shortage of them.
We have 3 wonderful medical schools in West Virginia. Thank you. I yield back my time. Now, Ms. Delbenny.
Thank you, Madam Chair. Thank you, Mr. Secretary, for being with us today. It's great to see you. I first want to commend you for working to improve prior authorization for seniors on Medicare Advantage. I've partnered with Congressman Kelly for years to make this archaic process fully electronic and streamlined so seniors can get the care that they deserve faster and so providers aren't buried in paperwork. Last Congress, we passed our legislation through the House with unanimous bipartisan support, a rare thing. In line with our legislation, I appreciate HHS's proposed rules to improve prior authorization, and I'd like to highlight your agency's detailed economic analysis, which found that these policies would save physician practices and hospitals over 200 million hours in administrative time over a 10-year period. That means a total cost savings of $15 billion. So as you work to finalize these rules, I encourage you to require real-time prior authorization decisions for routinely approved services and faster timeframes when there's an emergency. So please keep that in mind.
Absolutely will.
Now I want to turn to another important issue. More than 37 million Americans live with kidney disease, including more than 800,000 with kidney failure for which there is no cure. Although some are lucky enough to receive a transplant, most Americans starting dialysis will die within 5 years. That includes over 13,000 people who have kidney failure in my home state of Washington. Medicare spent $150 billion last year just on kidney diseases. That's over 18% of Medicare's overall budget. Yet the core technologies to treat and care for people living with kidney failure have not advanced much over the past 50 years. So I'm a strong supporter of the KidneyX program, which is speeding up the development of new treatments, particularly for the world's first artificial kidney. In January, along with my colleagues in the bipartisan and bicameral colleagues in the Kidney Caucus, I wrote the administration a letter requesting an increase in funding to $25 million, up from $5 million for KidneyX. Very humble request. I've sent similar letters in previous years. Unfortunately, the president's budget continues to keep funding flat for this critical program. This funding increase is an important, a small and yet very, very important investment that would be relatively, or especially compared to the current cost of treating kidney failure. Unlocking new treatment options would be life-changing for people with this condition and would significantly improve the fiscal health of Medicare over the long term. So when KidneyX was created, there was an expectation of $125 million from the private sector and $125 million from the federal government, and we're not meeting our end of the bargain. So given the success of KidneyX in its first 3 years and the president's commitment to preserve Medicare for the next generation, why isn't the administration doing more to prioritize this program, which could provide a revolutionary return on investment?
Congresswoman, first, thank you for championing KidneyX and being for such a proponent. I think you would find so many people at HHS who support what you've just said. We do have to do what we can with the monies that we have. We are limited, and whether it is kidney, I was answering questions in a previous hearing on asthma and how we should do more on asthma. We're not going to say we can't do more or shouldn't do more. We just need more resources, and so I'll put it back to you and say we look forward to working with you so you all can get us more money so we can do more with Kidney X.
This is a huge cost to Medicare right now, so I hope we can make a increase in the investment. Thank you so much. I yield back, Mr. Chairman.
Gentleman from North Carolina is recognized.
Thank you, Mr. Chairman, and thank you, Secretary, for coming. I want to just follow up on one of my colleagues' comments earlier, Dr. Winstrup. I personally also, as a physician, am dismayed. We sent y'all a bipartisan, bicameral bill signed by a president for the No Surprises Act, and you absolutely took it to the left and have hurt, I believe, Americans. And you talk about all the disputes that occurred, absolutely, because it was not interpreted as it was sent over. I'll just leave that as a comment. The one thing that you and I definitely will agree on is antimicrobial resistance. I've lost patients. I've seen, I think, records now about 35,000 a year that die because we don't have drugs to treat them. So I know you probably know some of this, but just for the edification of some of the other members, from the time it starts, from a drug starts from the beginning to a patented molecule sometimes takes 10, 15, even longer, that many years. And it costs billions of dollars of investment. And for every one molecule that passes through, there are probably about 100 and 150 that don't make it. From the time they patent a molecule, it gets a 14-year clock. However, now that 14-year clock has changed to 9 years. And as a direct result of that, so many pharmaceutical companies, because they cannot, and I'm not advocating for pharmaceutical companies, I'm advocating for patients. So many companies, pharmaceutical companies, have, because of that restriction of their ability to earn and recoup their losses, are stopping production. And for the record, Mr. Chairman, I'd like to submit an article as well as source of list of 42 companies that mention the IRA this year in delayed launches of their medications, impacts to long-term planning for new cures, and impacts to oncology R&D. And included in it, may I just submit these for the record, sir?
Without objection, so ordered.
And so we go back to the antimicrobial resistance. We really haven't had a new generation come along. We've had it in the quinolones, and now there's some fifth-generation cephalosporins that are helping. How can the IRA, and then with the fact that the Biden wants to have the moonshot program and develop these new cancer cures, how can that fit with the fact now that we are killing American R&D in trying to develop new cures because we're cutting their ability to actually fund for them?
Congressman, here's my difficulty in following the logic of your question. If a company is going to...
I think I was pretty clear. It costs money to develop drugs. We're cutting them out from earning that money so they won't develop the drugs.
And if they're putting that product out, that drug out there at a competitive price, what would be the problem? It's when you put a drug out there for an uncompetitive price where you essentially charge Americans 2 to 3 times more than what you charge others around the world. That's what the Inflation Reduction Act attacks, is that lets us negotiate to get the best price.
Well, tell that to the 42 companies now.
I would say that to the 42 companies.
That have stopped production of cures and treatments, which include antibiotics.
Competition should not stop anyone from trying to develop a drug.
But I'm not being pleading for pharmaceutical profits. Please don't take me it that way. But I'm saying it costs billions of dollars to do this, and now we have 42 companies that say they're not going to do it because of the IRA.
And how those 42 companies can make a decision on a law that just took effect and that won't be negotiating prices for several years to come is beyond me. But what I can tell you is
that's planning in the corporate America. That's planning. You have to plan 20 years for these drugs. That's how long it takes for these drugs to come out.
And you're entitled to plan to make a profit. You're just not entitled to gouge Americans for the price.
I agree 100%. I agree 100%.
So why would those companies not want to create a drug in America, the richest country in the world, so they could sell it and make a profit, not gouge, but make a profit?
Because their timeline to earn that profit has been cut by 30%. Thank you, Mr. Chairman. I'm going to yield back.
Gentleman from Tennessee is recognized.
Thank you, Mr. Chairman. Thank you, Mr. Secretary, for appearing today. I want to ask you about a New York Times article dated February 25, 2023. The headline, "Alone and Exploited Migrant Children Work Brutal Jobs Across the U.S." Arriving in record numbers, they're ending up in dangerous jobs that violate child labor laws, including in factories that make products for well-known brands like Cheetos and Fruit of the Loom. The article talks about migrant children have been coming into the United States without their parents in record numbers, are ending up in some of the most punishing jobs in the country, a New York Times investigation found. It says 12-year-old roofers in Florida and in Tennessee. The article goes on to say that the number of unaccompanied minors entering the United States climbed to a record 130,000 last year, 3 times what it was 5 years earlier, and this summer is expected to bring another wave. The federal government knows they are in the United States, and the Department of Health and Human Services is responsible for ensuring sponsors will support them and protect them from trafficking or exploitation. But as more and more children have arrived, the Biden White House has ramped up demand on staffers to move the children quickly out of shelters and release them to adults. Caseworkers say they rush them through vetting sponsors. While HHS checks on all minors by calling them a month after they begin living with their sponsors, data obtained by the Times show that over the last 2 years, the agency cannot reach more than 85,000 children. Overall, the agency lost contact with a third of migrant children. Mr. Secretary, is the New York Times correct that HHS cannot account for 85,000 migrant children in the U.S.?
Congressman, no, they are not.
Okay. What is the number then, Mr. Secretary?
You have to understand the responsibilities that HHS has. We do a follow-up check on these migrant children by contacting the children and their sponsors, but our authorities that Congress gave us go towards caring for the child while they are in our custody. Once they are in the custody of those sponsors, we don't have jurisdiction over the children. And so for the New York Times to say that we lost contact with them, it's not that we lost contact. We try to make an effort to follow up with them, but they're under no obligation to respond to us, neither the child nor the sponsor. And so the New York Times could have done a little bit more homework to figure out what HHS responsibilities truly are.
All right, let me ask this, because the article specifically says the agency cannot reach more than 85,000 children. You're saying that's an incorrect statement?
That's an incorrect statement.
And you do or do not know what that actual number is?
I can tell you the number of children that we have placed in the care of sponsors, and every one of those children we follow up with.
What is the number of children that you don't have contact with?
Congressman, as I just explained, we no longer have jurisdiction over the children once they are placed in the care. You didn't give us the authority to keep in contact with those kids.
You don't know what the number of children is that you don't have contact with, correct?
We make contact. We try to make contact with every child that has been in our care that we place in the hands of a sponsor.
Thank you. My time's expired. I yield back.
Representative from California, Ms. Chu is recognized.
Secretary Becerra, I want to thank you so much for your visit to my district in Monterey Park, California last month. The visit meant so much to the people of Monterey Park who are still reeling from the mass shooting that took 11 lives in January. The shooter was a person who was deteriorating mentally, who shouldn't have had a gun but did, and did terrible harm. The wide availability of guns in the wrong hands has fueled a drastic increase in gun violence deaths, as AAPI youth, in fact, have the fastest growing firearm suicide rate of any racial or ethnic group, with a 71% increase in the last decade. Because of this, I'll soon be releasing legislation to ensure that all communities, including limited English proficient and immigrant communities, have access to gun safety and prevention strategies, such as safe gun storage recommendations and mental health services for suicide prevention that are recommended by CDC. One part of the president's budget that is so important is an increase of $50 million for the suicide prevention program to expand CDC's work to reduce suicide. How will you ensure that this important research and safety guidance will be accessible to these LEP and immigrant communities?
Congresswoman, first, that was a special visit. I used to, as you know, I used to live in Monterey Park. I still have a home there. And you could see it in so many of the people's expressions, how not just painful, but how appreciative they were when anyone would give them a chance to just speak their mind. And speak their mind is important for your point, because oftentimes they're not able to communicate with authorities because they don't converse easily in English. We're doing everything we can to make sure that we provide culturally and linguistically appropriate services. The materials, we try to translate them into appropriate languages. The people we hire, we want them to not only know different languages, but also have lived experiences that relate to the people that we're trying to help. And in so many ways, we will try to support the work that you're doing to make sure that we are approaching people with services that can accommodate their needs.
Thank you so much. I'd like to have your comments on Title X and Medicaid. You know, Title X family planning has been flatlined for the last 10 years, and yet the need is greater than ever now. So I commend you and the Biden administration for proposing $512 million for the Title X family planning program, the first increase since 2014. And then there's the Medicaid unwinding. The continuous coverage requirement, you know, started during COVID, but unwinding this Friday, and millions can lose coverage. So can you speak to the importance of Title X, and also how does the department plan to protect those most vulnerable to losing coverage once Medicaid unwinding begins?
Congresswoman, we've been in conversations with governors throughout the country to make sure that they're aware of what's coming once the public health emergency comes down. We want to make sure that no American loses health coverage because the public health emergency has ceased. And we continue to work with states. Some are better positioned than others. Some are doing more than others. But every state is aware that there are a number of individuals, that could be close to 14, 15, up to 16 million Americans who could lose their coverage, even though they qualify for other coverage, whether it's through the Affordable Care Act or whether it's through existing Medicaid programs where if they reapply, they will still qualify. And we want to make sure everyone is aware of what is available to them, including employer insurance, which maybe they didn't have when COVID hit and they got onto Medicaid, but now they're employed and they have access to coverage. They need to know those things so we don't lose coverage for those Americans.
Thank you. I yield back.
Ms. Van Dyne from Texas is recognized.
Thank you very much, Mr. Chairman, and thank you, Secretary, for being here today. Mr. Secretary, as you know, the hospice care program is a vital part of the health care system, with over 50% of Medicare patients utilizing the program, but it's also one of the hardest realities that a family can endure. We know how personal this issue is for you, as you and your family provided for your father excellent end-of-life care. But not everyone is as lucky. The system has been overrun with rampant fraud and abuse, and your agency's response to this crisis has been extremely alarming. We've been told just last week to, quote, be patient while CMS investigates, but families only have one chance to provide excellent end-of-life care for loved ones. And while CMS asks for patience, more and more fraudulent hospice providers are gaming the system. They're stealing Medicare dollars, assessing opioid medication, and depriving patients of access to the care that they need. Mr. Chairman, I ask for unanimous consent to enter into record the ProPublica article entitled Endgame, How the Visionary Hospice Movement Became a Nonprofit Hustle.
Without objection, so ordered.
So, Mr. Secretary, we're well beyond the time to be patient, and the time for action is now. Families deserve more from this administration. We have a bipartisan group of lawmakers, including my colleague from Oregon, Mr. Blumenauer, ready to address this issue. And Mr. Secretary, you served as a member of Congress representing Los Angeles County and on this committee at a time when your district was seeing an increase in fraudulent hospice activity. You also served as the Attorney General of California as this crisis continued to build. Now you're HHS Secretary. How can we trust that you are finally going to take this issue seriously? Will you review how penalties actually prevent fraud? And when can we, honest to God, expect an answer from CMS on what is going on?
So, Congresswoman, I'm surprised you didn't get the answer that you wanted from CMS, and we can actually follow up if you like with CMS.
That would be great.
But they're not sitting around. we're acting aggressively. In fact, in this budget, we're asking for money to do exactly that, to go after the fraud and the abuse that's going on.
And I appreciate that you're doing this. And I know, look, we have 3.5 minutes because you limited your time in front of this committee. I'm going to be following up with requesting a legitimate answer in writing from your office. Now, I know that you actually do have a history of not responding to our requests for information from this committee, so I'm going to ask you, will you commit to answering my questions, which will be submitted for the record regarding hospice care?
Congresswoman, we make having been a former member of Congress who made requests for answers in writing.
So is that a yes?
We make every effort to
Excellent.
make sure we respond.
Thank you very much. I want to turn to a completely different topic, Mr. Secretary. Approximately 100 facilities nationwide, also known as pediatric transgender clinics, are performing gender-affirming treatment in the form of hormone therapy on surgery on children at age 11 or younger. There are even allegations that some of these clinics perform these treatments without conducting thorough mental health assessments beforehand, or even bypassing certain parental consent. 10 states have now restricted these treatments for children, including 8 states that ban this treatment for children outright. Are you aware of any medical facilities conducting pediatric gender-affirming treatment that either receive HHS grants or Medicare or Medicaid reimbursement?
Congresswoman, there are a number of facilities that could receive funding from HHS so long as it's a federally prescribed service, and so therefore we would make sure that they are using the monies appropriately.
So, Mr. Secretary, can you confirm that of these facilities, none of them are using a dime of federal taxpayer dollars to provide pediatric gender-affirming treatments to children?
Congresswoman, those facilities are under law required to make sure they are using any federally provided money in the appropriate way.
So they are, or they are not providing that service?
Now, you're asking me about every facility in the country. I can tell you that CMS has an obligation to make sure that we're doing oversight. If you help us with our budget, we'll do as much as we can.
I yield back.
Gentleman from Pennsylvania, Mr. Fitzpatrick, is recognized.
Thank you, Mr. Chairman. Thank you, Mr. Secretary, for being with us today. Mr. Secretary, my constituent, Phil Guttis, was diagnosed with early onset Alzheimer's 7 years ago. He received his diagnosis as part of a clinical trial for aducanumab, a drug, and has been on this drug for almost, I'd say probably the last 7 years or so. He will receive 2 more infusions as part of this trial, and then because of the discriminatory and unprecedented decision by CMS not to cover this drug and FDA-approved drugs like it, he will be faced with either wiping out his retirement savings to pay for the drug on his own outside of Medicare or go without treatment altogether. Mr. Secretary, never before, to my knowledge, has CMS refused to provide coverage for an FDA-approved drug. So my question, what does the administration have to say to the millions of patients, caregivers, and families who will be denied access to these breakthrough treatments, like my constituent Phil and many other people like him across America? And what is the administration doing to ensure that access to these FDA-approved drugs will be provided to our seniors?
Congressman, I would say to those individuals what my wife and I said to our own family members who, when we were experiencing these same issues of dementia, Alzheimer's, and that is we're going to work together. We will do everything now as a secretary. I will do everything we can to make sure that life-saving treatments are made available, whether it's first through FDA, which has to ensure that a drug can be put out onto the market safely and effectively, or whether it's through CMS, which has to make sure that for purposes of Medicare, that it is a drug that will get coverage under the Medicare program. But I will say it as secretary, as I would say it as the father or the son-in-law, or as the son of those who might be affected by these types of illnesses, that we will do everything we can to make sure that we are providing the care that they need.
We see everything you can. I mean, it's your decision. It's in your purview of your department regarding the decision of CMS to refuse to provide coverage for this medication.
Congressman, we apply the laws that you pass. And if the laws require Medicare services to go through a certain type of check, we have to abide by that law. The law that governs CMS is different from the law that governs FDA. If you wish to have the law that governs CMS be the same as the law that governs FDA, then it's up to you to make that change.
Lastly, Mr. Secretary, I have a question which is going to extend beyond my time, so I'd, Mr. Chairman, ask unanimous consent to enter this question into the record regarding the effect of GPOs and PBMs on drug shortages and drug prices.
Without objection.
And Mr. Secretary, if I could get your commitment to timely respond to this, this question that we enter.
We'll make every effort to respond as quickly as we can, Congressman.
Thank you, sir. You're back, Mr. Chairman.
Thank you, Representative. Recognize the lady, the gentle lady from Wisconsin, Ms. Moore.
Thank you so much, Mr. Chairman, and I too want to thank you, Secretary Becerra, for coming to my district and really doing an amazing job to educate my community about the importance of the various investments that have been made in our community. Just very quickly, I'm looking at your written testimony, and on page 5, you said the budget also proposes to further expand the healthcare workforce by allowing community health workers to be able to bill for select services under Medicare. Can you share with me what those might be? That's very exciting.
I'm sorry, can you pose the question?
Your written testimony says that you're going to allow community health workers to be able to bill for select services under Medicare.
We're trying to move both the Medicare program and the Medicaid program to a space where we make access to services more readily available, because one of the things that we found, Congresswoman, is that too often people are deprived of services even though they're eligible for them because they don't know how to access them. And so whether it's in Medicare or Medicaid, we're going to do everything we can to make sure access is made most available.
Thank you, Mr. Secretary. I am so pleased to see that this is like a dream come true, to look at a budget that's really centered around children and women, and I don't have enough time to address everything, but I was curious about the foster care provision that was just came on board in January 2023 that would enable foster youth to have Medicaid through age 26. And I am concerned about the implementation of that program, whether or not there is a sort of plan to contact foster youth who may or may not know that have aged out of foster care that they are still eligible for Medicaid.
Yeah, that's one of the biggest issues is when you leave the foster care program, sometimes there's no safety net to catch you. We're going to try to do what we can to follow up. Simply because you turn a particular age, 19, 21, depending on what it is, it shouldn't mean that all of a sudden you fall over a cliff when it comes to the services that you need. Some of our foster kids, as you know, are the most in need of service. They're the ones that are calling the 988 suicide prevention hotline
Exactly,
more often
exactly.
than not. So we are going to do everything we can to make sure no foster care child believes that they are second class.
I am really happy to see that that you're very intentional about moving into mental health. And you know, we talk about mental health parity all the time, at least as long as I've been a member of Congress. And so I'm wondering what, in particular, that we wrap our arms around, are you doing to make sure that mental health parity is more than just a conversation?
Congresswoman, we're doing as much as we can to get insurance companies to follow the law. And so that if you are at an insurance company and you provide reimbursement for physical health care benefits and services that a patient receives, that you are also providing reimbursement for mental health services in an equitable way.
This is a really big problem. I mean, you know, for women postpartum have severe depression, and it has a real impact on the well-being of the entire family. You know, when mama ain't okay, nobody is okay. I yield back.
Gentleman from Florida, Mr. Stubbe, is recognized.
Thank you, Mr. Chairman. On January 30th of this year, a Cochrane report was released, and it found that for, and I quote, medical or surgical masks, and in a separate analysis for N95 P2 respirators, and I quote again, compared with wearing no mask in the community studies only, wearing a mask may have little to no difference in how many people caught a flu-like illness or COVID-like illness. Are you aware of the analysis that I'm referencing?
Congressman, I've heard of a lot of analysis. I know at the end of the day, wearing a mask has helped keep Americans alive.
Well, not according to the Cochrane. The medical and surgical mask analysis reviewed 9 studies in over 276,000 people. The N95 P2 analysis reviewed 5 studies in over 8,400 people. But then on March 10th, Cochrane put out a statement noting that their analysis was actually inconclusive and that the exact quote from their analysis that I just read was, quote, misleading, after they had just found all of that based on all those studies. So it's clear that somebody in the administration or somebody somewhere influenced Cochrane's attempt to backtread from their previous findings 3 months prior. So my first question is it true that you had conversations with Cochrane regarding their January findings after their report was released?
If your you refers to me, that's not true.
Okay. Did anyone acting on behalf of HHS contact Cochrane about their January 30 findings after their report?
Best I know, no, but I can try to find out if you'd like.
So would you be willing to give any documents or correspondence that anybody in your agency had with Cochrane between January and March 10th of this year?
We will provide to you whatever documents are disclosable by law.
Okay, I'll put that into a letter. Is it true that someone from HHS or the Biden administration pressured Cochrane to change or back away from their January 30 findings?
I know nothing of that ever happening.
So you're not aware, but you're saying that you're not aware that somebody in the agency may have had conversations with them?
As far as I know of no one in the agency who just engaged in that kind of a conversation.
And your testimony here today is that you'd be willing to provide correspondence between anybody in HHS with Cochrane after January of this year, after the findings?
We are prepared to provide you with whatever documents legally you're eligible to request.
Okay. Has HHS ever contacted social media platforms such as Twitter or Facebook to pressure them to remove statements about COVID-19 that the administration didn't want circulated?
I believe now you're making reference to some lawsuits that sort of make those kinds of allegations, but I can say to you that I'm not aware of anything like that, at least not for me.
So you've not had any conversations with any social media platforms about anything related to COVID and the information that they're putting out to the American public?
Other than perhaps using some of these platforms to put out information.
So you have had conversations with social media platforms as it relates to putting out information?
I have put out information on some of these social media platforms. I have not had conversations with the representatives or the leaderships of these platforms trying to influence them to do one thing or the other.
So your testimony is you put things on platforms, but you have not had conversations with executives or anybody at Twitter, or Facebook, or otherwise?
Now you're stretching it. Have I ever had conversations?
No, I'm following up on your testimony.
Okay, so the answer is there may have been occasions for me to have conversations with executives from any of those media platforms on any number of subjects.
Did Surgeon General Vivek Murthy participate in meetings with White House officials and social media company officials discussing what information should be hidden from the public?
I suggest you ask Surgeon General.
Are you aware of any conversations that they had?
I know that he has conversations with lots of entities and individuals, but I couldn't specify if in this particular case.
I'm asking if you are aware that he had conversations with those social media platforms.
I am not aware.
Mr. Chairman, I ask unanimous consent to add to the record the Cochrane Library analysis, physical interventions to interrupt or reduce the spread of respiratory viruses, and the Cochrane 3 months later statement on physical interventions to interrupt or reduce the spread of respiratory viruses.
Without objection, so ordered. Representative from New York, Ms. Tinney, is recognized.
Thank you, Chairman Smith and Ranking Member Neal, for holding this important meeting. And thank you, Mr. Secretary, for testifying before the committee. Over the past couple of years, many of us have shared numerous concerns about the Department of Health and Human Services prioritizing politics over its duty to promote and protect the health and welfare of the American people. This has included the HHS insistence to keep the unscientific CMS healthcare workforce COVID-19 vaccine mandate, referenced by my colleague from New York, Mr. Higgins, which has exacerbated healthcare staffing shortages, especially in rural districts like my own in upstate New York. The department has also spent time altering Medicare payments to re-incentivize doctors to develop anti-racism plans, for example, instead of boosting health care quality for all patients. At the same time, HHS has failed to properly implement bipartisan surprise medical billing provisions passed by Congress or reform its guidance to allow seniors to access new innovative treatment for Alzheimer's disease, as my colleagues have referenced. But I want to jump right into this issue about vaccine mandates, if I could, Mr. Secretary. Over the past few years, multiple scientific studies have found that the COVID-19 vaccines do not reduce transmission of the virus. In fact, our own CDC director, Dr. Rochelle Walensky. She's a doctor of medicine, unlike you and I, or doctor of laws. She said, in referencing the COVID-19 vaccine, what they cannot do anymore is prevent transmission. So you just stated in your testimony today that the reason we're extending this vaccine mandate, especially on healthcare workers, until November of 2024 is because of the transmission of the disease. This is causing huge problems in upstate New York in terms of staffing, as I indicated. In the Finger Lakes region and Buffalo region, which I share with Mr. Higgins, hospitals have had a 375% increase in contract labor costs due partly because of the vaccine mandate, having to hire visiting nurses, which are much more costly. There have been protests and a lot of objections to this vaccine mandate, particularly among nurses and those who served, those heroes who served when we didn't have a vaccine, who now have been laid off and lost their jobs, and we think this is unsustainable. What are your plans under CMS, and I know you've indicated to my colleague, Ms. Miller from West Virginia, what are your plans in dealing with this vaccine mandate now that we know that this is not transmissible by Dr. Rochelle Walensky, our CDC director? Would you be willing to overturn this vaccine mandate earlier so that we can get people back to work in New York and really provide the health care we owe to our patients?
Congresswoman, thank you for the question. And as has always been the case, whether, and you could ask this of
Can you just ask the question, would you be willing to do that? Because I want to also add, a New York judge actually just struck down the vaccine mandate in January. So is this something you're willing to do to override this based on the law and also based on science?
The actions are taken based on science and the evidence, and that will continue to be the case.
So Dr. Walensky is not accurate as a doctor in determining that these vaccines don't transmit the disease?
So I'm not sure about the quote that you attribute to her, but what I could tell you is that Dr. Walensky, like all of those who are working on COVID within the Department of Health and Human Services, base their actions on science and the evidence.
Would you be willing to waive Novak Djokovic's entry into the United States to play in the U.S. Open tennis?
So you give me more power than I have, authority than I have.
Do you oversee the CDC?
CDC does not make the decision about who can come in and cannot come in. Those are issues that relate.
They could issue the waiver.
I'm sorry?
The waiver could be issued.
A waiver for one individual?
For anyone that's coming in. I mean, we have illegal immigrants crossing our border every single day who don't actually take the vaccine.
We provide the vaccine to those unaccompanied migrant children who do come into the country, yes.
And what about American citizens who choose to play in these sports that don't take the vaccine? They're waived from coming in. Are they dangerous to the...
American citizens are able to...
Is that science? I mean, I'm just saying, we allow American citizens unvaccinated to play in the U.S. Open. So is that scientific? Should we mandate that they are vaccinated in order to play in sporting events, for example?
The actions that our administration has taken with regard to American citizens is to protect them as best possible against COVID. The actions we take with regard to those trying to enter the country are somewhat similar, but there are some differences because these are folks who are asking for permission to come into the U.S.
Would you say the decisions are political at this point?
Yep.
The decisions are based on science and the evidence.
My time is expired. Thank you very much.
Thank you. The gentleman from Michigan, Mr. Kildee, is recognized.
Thank you, Chairman Smith and Ranking Member Neal, for holding this hearing, and thank you, Secretary Becerra, for being here this morning, and in particular for discussing the proposed 2024 budget. You and I serve together here in this body. I consider you a friend, and I'm glad to have you here with us, and I appreciate you addressing some of these issues. I'm pleased with the priorities that I've seen come forth in the aspect of the budget that you have responsibility for. I'm particularly pleased that the budget includes $5 million for the Flint Lead Registry, which, as you know, is a powerful tool to help improve the lives of kids, families that I represent in my hometown of Flint that have been exposed to lead-contaminated water. And I do appreciate this being a priority for the department. Because Mr. Kustoff raised it, I want to give you an opportunity to address some of the work that you are doing on this issue of child labor violations. I know that you most recently have stood up a task force to address this issue. It is a serious issue. It's one that we have to take seriously, and Mr. Kustoff raised this issue, as I have with you, privately in the past, we do know that in part this is really a question of your authority. But even to the extent that you do have some authority, it's also an issue of resources. And that's why I am happy to see $39.4 billion for the Department of Health and Human Services Administration for Children and Families in the President's budget. It's ACF that works to protect the well-being of unaccompanied children by assessing the placements that they will be placed in connection with the other resources that they'll be provided. And because a budget decision affects what you are able to do, I wonder if you might just tell us how cuts, which I do believe some would advocate for, cuts to the Department of Health and Human Services Department's Administration for Children and Families would impact your ability, even given the authority that you have, to protect children from exploitation.
Well, Congressman, that's a broad question, but what I can tell you is if we lose some of the funding we have within the Administration for Children and Families, we would have less opportunity to provide the child care services support, the Head Start services support, to be able to, with regard specifically to the refugee program, and within that, the unaccompanied migrant kids program, be able to provide the level of custody care that we provide. And so you impact kids in so many different ways. And as I say, children are children. And whether they're your children or my children in this country, we should let children be treated as children.
Thank you. And I guess finally, do you know, and I hope you do, that the administration would support my efforts to increase the civil and criminal penalties for employers? Because look, we need to hold people responsible for this. You know, you have some regulatory authority, but employers have a responsibility. Those employers who are illegally hiring children in dangerous jobs need to face stiffer criminal and civil penalties. And I ask if the administration would support our effort to do just that.
You hit it right on the money, Congressman. If an employer, if a company wasn't willing to hire against the law these children, we would not see the type of exploitation. And that's the heart of this, is we should not be allowing this to happen right in front of us.
Thank you, Mr. Secretary, and thank you, Mr. Chairman. I yield back.
Thank you. The gentleman from Utah is recognized.
Thanks, Mr. Chairman and Ranking Member, Secretary Becerra, for being here today and for putting in the time to dialogue with us on these. This is it. This is the most crucial, most important matters of our nation, is getting things related to health care figured out. This is something in every single district across the board. So incredibly important. According to a recent estimate, 250,000 Americans die each year due to medical error. This is an issue Congress and CMS have tried to address for decades through quality measure activities. However, a 2019 GAO report noted that CMS failed to properly track its spending on quality measurement activities and how its spending is or isn't helping it achieve its strategic objectives, such as lowering administrative burdens. We talk a lot about administrative burdens, but sincerely, this is an area that we could truly lower administrative burdens. My team and I think that this could be a significant win and a bipartisan win in the 118th Congress. I sent you a letter yesterday asking 5 detailed questions on this topic. Will you commit to answering these questions in my letter by the end of April? Would that be enough time for you to consider this?
Okay, well, so
Having not seen the questions,
I haven't seen the questions, but I commit we will respond, and we'll try to do it as best we can, as quickly as we can.
And we will follow up, and once you've had a chance to look at them, I've got a copy of it here today. Would love a sense for not just when you're going to, when you will have time to get to them. We're going to drive this Congress, and time's running out. We want to get this going. So,
having sat where you sit today, I know how important it is to get the answers.
So, some more context on that. If you'll commit to working with us to make these quality measures outcome-oriented and transparent, would you be willing to, having seen that, without seeing the exact questions, making this outcome-oriented, transparent, we think is a significant bipartisan win here, so that they are indicative of the quality of care patients actually receive, and that patients aren't, in some cases, forced to shop around for their health care in the dark.
Congressman, looking forward to working with you and reading this letter.
Okay, thank you. Finally, last piece here on the budget. Your budget claims to extend Medicare's solvency by 25 years. I looked at this, my teams looked at this, and your plan, the way we view it, does this primarily by funneling existing general tax revenues to the Medicare Hospital Insurance Trust Fund. So you got the trust fund, you got general. This is funneling them over into the trust fund to extend that solvency. According to CBO data, if Medicare is allowed to run its course and we merely finance it by borrowing against our children's future, Medicare will add over $17 trillion to the national debt over the next 25 years, just in additional interest payments. When you and the President formulated your budget, did you consider the cost, the specific cost of additional interest payments caused by borrowing?
And Congressman, again, I don't understand that math because the President's budget, as opposed to what you've described, the President's budget actually reduces deficits. It not only extends the life of Medicare and strengthens it, but it reduces deficits moving forward into the future. It makes some painful decisions that some folks may not like, but it does protect Medicare, those benefits, and it does continue to make it available, not just for today's seniors, but the next generation.
So we've had an opportunity to dig into this in the Budgetary Committee, and there's definite there's argument over whether that truly does reduce deficits here.
I'd love to go through those numbers with
one
anybody.
pot and just pushing it into the other, we're reducing this. We're not truly going after the solvency here.
Again, I disagree with that, and I'm more than willing to sit down, go number to number, mano a mano on that one, because the President made a commitment. It is real.
We'll gladly sit down and go mano a mano anytime on these details. Thank you.
Thank you.
Ms. Steele from California is recognized.
Thank you, Chairman Smith, and thank you, Secretary Becerra. You're coming out, and you know how many hours you've been here for testifying, so I really appreciate that. You know, I am concerned about Center for Medicare and Medicaid Services oversight of new hospices and home health agencies. This is particularly an issue in California, which instituted a moratorium on state licensure January 1st, 2022. Despite this moratorium, hospices in California that previously received state licenses are still being certified by Medicare. In fact, 443 California-based hospices received Medicare certification in 2022. 375 out of 443 were issued in LA County only. Considering the moratorium in California and the state auditor's report highlighting these bad actors, why is Medicare still certifying hospices that are likely engaging in fraud?
Congressman, that's a great question. I'm not totally abreast of what the state of California, my state, is doing, but as you will recognize, the laws that guide us on Medicare and hospice care are different from what guides the state of California. What the state can do isn't necessarily what we can do, and vice versa. If someone applies to provide hospice care, we have to make sure that what they're doing is fulfilling the criteria that by federal law they must achieve. If they do, we don't have the luxury of saying, no, we won't, because your state is saying you may not be a good actor. We have to base it on the information they provide to us and if they meet the criteria to qualify for funding under Medicare.
So who does the audit?
Who does what audit?
These are hospice carers, especially hospice care takers.
If you're talking about the work that the state has done to suspend further licensing, then it's the state who would do some of those audits. If you're talking about the Medicare program, that's a federal program. The state does not operate Medicare.
So Medicare certifications, they were just still giving out to these fraud cases.
Medicare would not give out a
certificate
for operation of a hospice care program if it was doing it fraudulently. Those programs would have to be able to show that they meet the criteria. If they subsequently commit fraud.
So who finds out that they are fraudulent certificates or not? Who finds out? Because Medicare certificate that we are talking about here.
That's where you rely on the surveyors, the investigators who periodically go in to see how those programs are operating. The state might have some folks who are doing it. When I was Attorney General in California, we had the authority to go in and look at all of these different facilities for how they were caring for folks. That's why we expanded the program that actually looks into nursing homes. That's different from what the federal government does.
So, you know what, let me just change the issue. I'm going to go a little more deeply, and I'm going to work with you about this, fraudulent certificates. But like last week, constituents of mine from Fullerton and Placentia rallied on Capitol Hill about CMS decisions to deny senior access to vital Alzheimer's treatments. What do you expect me to tell my constituents about not having access to care because USC, Stanford, UCLA, UC Irvine, UC Berkeley, UC San Diego, these are just really good universities. They all say it's a breakthrough medication. So why not?
Congresswoman, I would tell you to tell them that you will advocate as hard as you can to make sure that where possible, we will make access to those medicines and services that help them with their particular condition or disease. And if they probe even further, you might want to make sure you can tell them the distinction, the difference between the work that the FDA does to make a drug available and the work that CMS does within the Medicare system to make those drugs available for reimbursement within the Medicare program.
So how are we going to do that, though? Because they're not reimbursing it. They've been denying those coverages.
That's where what I'm saying is people have to understand how CMS and Medicare operate so they can understand the decisions, the determinations that are made by CMS. CMS did provide some coverage for some of those Alzheimer's drugs, but under certain conditions.
This is a new one we're talking about. Yep. Yeah, you know what? My time is up. I'm going to do in writing, and I'll ask all these questions. Actually, I have more than 10 questions here that I want to ask you, but I just don't have time, so I yield back.
Thank you, Representative. Representative from Virginia, Mr. Byer.
Mr. Chairman, thank you to you and Ranking Member Neal for hearing this hearing. Mr. Secretary, welcome back to Ways and Means. It's great to have you back. I want to praise the work that you have done and CDC and SAMHSA on suicide prevention. As always, there's a lot more work to be done, but I'm really proud of this administration's budget, your intent to take suicide seriously. And the $80 million directed just to the suicide prevention program at CDC for fiscal year 2024 is just wonderful. You know, one of the biggest pieces has been the transition to the lifeline to the 988 number, and you mentioned it in your opening statements. Thanks, by the way, to Mr. Moulton, a Democrat, and Mr. Stewart, a Republican, their leadership on this issue. And we successfully secured funding to help that transition last year. But, you know, when it went into effect in July, there was a huge surge in August in that number. And right now, I think SAMHSA expects calls to double in this next year as word is getting out about the 988. And one of these pieces of this conversation is trying to get an awareness campaign going for the new number and for suicide resources broadly, because how we treat it today is much different than when we were kids. And this, by the way, was something that Governor Gianforte and Mr. Kinzinger both partnered with me on in years past. And I was encouraged to see that this year's president's budget called for an awareness campaign similar to the bill we had last year, the Campaign to Prevent Suicide Act. Can you just speak to us as the leading healthcare official in this country about why this is so important?
Congressman, I don't know if there's anyone in America who hasn't lost a loved one at some point because of suicide, drug overdose. It is amazing to see the age of some of the people who are calling into 988, children, preteens. You hear the stories from parents about how they're not sure what to do, that their kids are suffering. You hear the stories directly from the children. America is hurting. COVID didn't create it. It just really exposed some of what's going on. And the president is very committed to 988 because it is a way to say to them, to people who are hurting, we're here, we're listening, and we're here to catch you. And thank God, working with all the states, we were able to stand up a program that actually works. And now the president wants to continue to double down, do even more, and I hope you'll help us with that because we want to do 6 million additional contacts.
Great. Thank you. One more question. I'm intensely interested in looking how we can decrease costs within the healthcare system. And AHRQ, ARC, a foundational agency that helps tackle much of this work. Yes. And I've been particularly interested in the role of all payer claims databases. You know, state after state have picked this up, and wonderful to have all that data to pull together state by state. But what we really need is a federal all payer claims database that bring this all together. And I know your budget looks at supporting this work within ARC. Can you speak to what you might see as the benefits of an all payer claims database on a national level?
we'll get to see what every country is doing better, and we'll get to pass along the best practices to every part of the country, because by collecting data and having it from all parts of the country, we can let folks see what's working and what's not. But if you're never seeing the data, you'll never know the success stories or the failures, and we'll continue to make the same mistakes. And so we're hoping that we can do a far better job of collecting that data nationally, because there's so much data out there now. It's just that we don't have, in some cases, the authority, or in some cases, the capacity to collect it. But boy, if we were able to collect it, Congressman, the stories we could tell and the improvements we could make in the healthcare system.
Thank you, Mr. Secretary, very much. I yield back.
Thank you. Ms. Fishbach from Minnesota is recognized.
Thank you, Mr. Chair. I appreciate the opportunity. And, you know, I'm going to just power through these because I've got a few questions. Secretary, throughout my district and across the nation, nursing homes are already struggling to maintain current staffing levels and have an even more difficult time finding new staff members to fill vacancies. And I know there was some discussion about nursing homes, but President Biden's additional staff ratios requirements on top of the ongoing workforce shortages would greatly reduce the number of patients served in facilities. Secretary, do you agree that long-term care facilities are facing labor shortages?
Congressman, there's without a doubt that the whole healthcare system is facing shortages.
And I agree with that, Mr. Secretary. And could the president's new staffing ratios force nursing homes to reduce the number of patients they can serve, or worse, even close their doors entirely?
Here's where we probably diverge, because I would say the most important thing about any nursing home facility is that they offer quality care. And if you can't offer quality care, maybe you shouldn't have your doors open. And that's why we want to make sure that if you're open, first and foremost, you care about the people that you're serving, which means you have to have the level of service that's required for the people that are needing it.
Is staffing ratios the only is the only measurement of care?
Oh, no, no.
Quality of care?
No, there are many
Okay.
measures.
So that,
But staffing ratios, but staffing levels
but
do make a
potentially you
difference.
could close nursing homes, I think is what you had said.
By
You could.
themselves, they shouldn't be the reason you close. If
Well,
you
if
have
they
the
can't
correct
get
number
enough
of staff.
And Mr. Secretary, if they can't get enough nurses or nursing staff,
What if they don't provide enough nurses? Is that good?
that's not the issue here.
Oh, yes, it-
Because it's ratios, and you're going to increase those and make it already more difficult, difficult to get nurses. And I think you agreed with that.
Talk to any nurses and they'll tell you, you can't have them do everything for everyone. You need to have enough nurses in a facility.
Nurses
to
and
do it right.
CNAs and LPNs, nursing
Absolutely.
staff. And, you know, though, Mr. Secretary, if I don't know who you're talking to, but I do think maybe you should talk to some of the rural folks that are struggling to keep nursing homes open under the already tight ratios, and provide people care close to their families and close to their homes. And but I've got to move on.
Congresswoman, I assure you, we've been
because
talking to
I'm,
folks in rural
reclaiming my
America
time.
about this.
Secretary, the Hyde Amendment protects taxpayers by prohibiting taxpayer funding of abortion. And as you well know, this language, this vital language, has been included in appropriations bills every time since 1977 with strong bipartisan support. Does the president's budget request include the Hyde Amendment language?
The president's budget does everything possible to make sure that women are entitled or
Well,
afforded
but
the
I asked you
care
a
they
very direct
deserve.
question, Mr. Secretary. I think it's a yes or no. Does the president's budget request the Hyde Amendment?
Well, the Hyde Amendment is something that Congress has added, and it's up to Congress to determine whether it will add the
So
Hyde
does the
Amendment.
president want the Hyde Amendment included in that budget request?
The president's budget does everything possible to protect the reproductive health care rights of
Okay,
all
well,
women.
I'm going to take, Mr. Secretary, with all due respect, I'm going to take that as a no. And the Dornan Amendment, I'm assuming that's also a no, that's not included in the language in the legislation either. And I don't know, I should at some point find out for sure. I know we've been looking for language on the budget if we've gotten that, but I'm going to assume that neither of those are included. And because you didn't answer with a yes or a no. But you know, this really does leave Americans. This is something since 1977 that's been included on with bipartisan support, and it really does leave Americans vulnerable to being forced to pay for elective abortions. And even though the majority of Americans are opposed to tax dollars going towards abortion funding, but I understand that under this budget, the Democrats would rather appease their extremist base that wants federal funding for abortion on demand. And I just say it will be very, very sad that the left is forcing this onto Americans. With that, I yield back.
Gentleman from Pennsylvania is recognized.
Mr. Secretary, it is a pleasure to have you come back before this committee. I've enjoyed listening to you. This year, no one on Medicare will pay more than $35 a month for insulin. The question I'd like to ask you, Mr. Secretary, can you please explain and discuss how the change helps constituents in Philadelphia and across the country?
Congressman, the benefits are immediate. I can't tell you how many folks that have come up to me and said, I can't believe it. In December, I was paying, I think this one woman was paying $117 for her insulin for a month. And she said, I got charged $35 in January. I went back to the provider and said, hey, I think you underbilled me. And when they said, no, that's the new price, she was ecstatic. And that is something that's being repeated over and over because the savings are not just real, but they're current. And I will tell you that in your state of Pennsylvania, the savings on average to this year for Americans who are on Medicare and need insulin will be somewhere around close to $550. That's $550 in their pocket that they would have had to otherwise spend to buy their insulin. That's the average. That means some people are saving a little less, but it means there are a whole bunch of folks who are saving a lot more.
I want to thank you. You're back. Thank you very much.
Gentleman from Iowa, Mr. Feenstra is recognized.
Thank you, Chairman Smith and Ranking Member Neal, and thank you, Secretary Becerra, for being in front of us today. I just got a quick question. Do you support a single-payer system?
Congressman, I have worked for many, many years to make universal health care coverage available to all Americans. And now as a secretary, I put into place the president's proposals, which include lowering costs.
So you're simply saying you can't answer the question and you're going to dodge the question.
I've always been for universal health care to make sure
So
every American
here's the
has access.
question. Here's why I asked that. I listened to all my colleagues, and the responses that I've got, it seems like we're going down that path very quickly. When you start capping, obviously, pharmaceuticals, that crushes the research and development. When you cut or don't update your reimbursements, that obviously dramatically hurts rural hospitals, rural clinics, doctors, and so forth. And then the elimination of 2,200 codes is an actual crusher. So my question to you is this: if you dramatically increase taxes on a business, do you think that business will pass those increased costs on to the consumer?
You're asking me a question which is speculation.
All right, you're not going to answer that. Let me say this: cutting payments to health plans, in the end, it will be the patient that bears the cost. We've seen this time and time again. It happens. And the recent analysis suggests that this will be about $540 per month per member per year. So the Biden administration highlights its desire to lower costs on health coverage and provide better benefits, yet the 30 million seniors and people with disabilities who choose to enroll in Medicare Advantage, which is close to 50% of them, will see either their benefits reduced or their costs go up. So how is the administration and yourself, how do you explain that to these customers?
Because, Congressman, there is nothing in our proposals that would cut Medicare benefits. I defy you to find me something in our proposal. That's what the commercials say that are paid for by the industry.
So this is you singularly saying this, but you want to know something? 150 groups that represent patients, providers, and plans. I yield back. 150 groups representing patients, providers, and plans are saying that this will happen, including American Medical Association. So who's right, yourself or 150 other groups that are saying this is what's going to happen?
Take a look at the proposal. It makes no cuts.
Your proposal is arbitrary, and if I had a guess, if I look at the real nuts and bolts of it, It's wrong. Now we're arguing.
We're not arguing, Congressman. It's just the fact that we're not getting paid money to do those commercials.
I haven't just fallen off a turnip truck. I have my PhD in healthcare administration. I see what's going on here, right? I see what's going on. And if we were here next year at this time, when all the MedAdvantage plans go up or their benefits are lost, I'd love to hear what you have to say. Thank you, and I yield back.
They cannot cut those benefits. That's the deception that's going on. They cannot cut Medicare benefits. They can tell people that, but they can't cut those benefits.
Gentleman from Illinois, Mr. Snyder, is recognized.
Thank you, Mr. Chairman. It's always good to see you, and thank you for making the time to be here and your patience. It's critically important that we continue to make the progress we've made on expanding affordable access to health care. As you talked to, it's been a lifetime devotion for you, and I appreciate your work, and we'll continue to do so. I take great pride in the fact that in the decades since ACA became law, the number of Americans without health insurance has dropped by almost half. Pre-existing conditions are no longer a barrier to getting health insurance. Kids are able to stay on their parents' program until age 26, and lifetime caps are history. And that's just a few of the highlights of ACA. I want to focus on telemedicine. According to the CDC, just in 2021, more than 1/3 of Americans made use of telemedicine in the previous year. Prior to the pandemic, I don't want to speak for everyone, but I would suggest that this panel ran the spectrum from curious to skeptical on telehealth. Post-pandemic, I can promise you that this is a room full of evangelists singing the benefits of telehealth. Telemedicine has improved access for virtually every American, including those who live far from medical facilities, those who don't have ready access to transportation, folks in need of mental health who can't find a provider with an open appointment near them, or maybe are just too shy to go in public because of the perceived stigma. So with the emergency coming to end in May and the pandemic winding down, we have to consider how we're going to take the lessons learned from telehealth and make sure that they stay strong. I will soon introduce my bill, the Primary and Virtual Care Affordability Act. This bill would extend the temporary provision that allows HSA-eligible high-deductible plans to waive the deductible for telehealth services. I'm also joining with my colleague, Ms. Steele, as co-lead on her bill, Telehealth Expansion Act, that's being introduced today, and may have already been introduced, to make telehealth flexibility permanent. My questions for you in the last minute is, can you speak to the administration's other actions to expand telehealth services, and how do we build on this progress to make sure telehealth is something that is part of our future?
I'll mention one thing that actually is not within HHS's jurisdiction, which is crucial if you're going to get your bill passed and deployed, and that is that broadband has to be made accessible to all communities, because you can do telehealth if you've got good broadband. But if you don't have good broadband, you can't do the connection. And so we want to make sure all communities have decent broadband so they can take full advantage of telehealth. The other thing we want to make sure we do is get people trained up. So especially places like rural America, we get providers, physicians who are ready to use telehealth, because in some of those communities, that's where it's going to have the greatest advantage. And so we want to make sure folks are ready for this time. And then finally, we're going to need to work with you, because the end of 2024 will come soon. Those extensions for telehealth will be upon us before you know it. And what we don't want is for a whole bunch of providers to be wondering, can we or can we not continue to do this? The clock is ticking. Better we take care of it early to give predictability to those providers of how we'll do telehealth.
My hope is we can extend telehealth long before we get to the deadline in 2024. Thank you. I yield back.
The gentle lady from New York, Ms. Maliatakis.
Thank you, Mr. Chairman. Thank you, Secretary, for being here today. This administration talks a lot about setting what I would call innovation-killing price controls. But one of the things I do want to talk to you about, where I think we could really work together on access and affordability of prescription drugs, would be PBMs. Okay? Obviously, our pharmacy benefit managers, which It's troubling to me that the three largest PBMs actually control 80% of the market. There's no transparency. They are making a lot of money by keeping rebates instead of passing them on to consumers. They exclude drugs from their formulary, and they are dictating what their competitors are making, right? And they are crushing my small mom and pop pharmacies. Here you have PBMs that are also the insurer, and then they're the pharmacy, and they're controlling everything in terms of pricing, okay? For example, right, CVS Caremark, they also own the insurance company Aetna, and then they own the pharmacies, CVS's all over the country. Now, do you think that is a problem?
Congresswoman, PBMs have, you know, no one knows everything they do. We're surprised sometimes when we see what comes out, and there absolutely has to be more transparency in the way they do business.
Well, the FTC recently announced their plans to probe the largest 6 PBMs in the U.S., and with the role that PBMs play in Medicare drug pricing, can you explain why HHS has not launched its own investigations, is not pushing for more transparency in order to shed some light into this very opaque process?
Oh, Congresswoman, let me assure you, we are working in this space. You may not have seen a particular rule come forward, but we are absolutely working in this space. And if you're interested, we would love to work with you because this is an area where reform is needed.
You say you're working in the space. How so?
Some of the work that we're doing is in the process of, we're trying to get some rules ready that would deal with some of this. At the same time, we're trying to avoid some of the lawsuits that are being filed. And what we're trying to do is continue to give consumers access to some of these prescription drugs at the best cost we can get them for them. And it is difficult, but we are trying to do what we can, working within the constraints we have within the laws, because we can only go as far as the authorities you've given us.
Well, I think the administration has, I think, a unique position to be going after the PBMs, actually. And you mentioned rules. You said, did I see a rule? And then you said, well, we have some rules coming out. So, you know, I think that needs to be clarified there that maybe you haven't done anything just yet. But I'm just trying to understand why HHS seems to be sitting on the sidelines and giving PBMs, you know, free rein, considering the role that they're playing, particularly in Medicare prices, but also just pharmaceutical drugs for all our constituents who are paying just way too much right now. And it is because of the games that they're playing and the lack of transparency.
Yeah, I can guarantee you we are not sitting on the sidelines. As we talked about insulin, it's $35 a month. We're
well, that's a price control. That's not going after the PBMs.
But we're affecting the price of drugs. We're making them more affordable, and that's what counts. And ultimately, the work, whether on PBMs or in making sure we can negotiate prices for drugs, it's to make sure consumers, Americans, get better prices for their medication.
I've run out of time. Thank you.
Gentleman from Ohio is recognized.
Mr. Secretary, good to see you again. In 2020, the Centers for Disease Control and Prevention reported that Ohio had the 5th largest overdose death rate in the country. In the same year, Ohio, fentanyl was involved in 81% of all of the overdose deaths, often with a combination of drugs. Last year, Drug Enforcement Agency seized enough fentanyl to kill every American, capturing more than 50 million fentanyl-laced pills and over 10,000 pounds of fentanyl powder. I've been to the border. I've seen how the cartels are able to smuggle drugs into the communities. And we need HHS to protect Americans from the fentanyl flooding our border. We need to hold Mexico accountable and continue to warn Americans about the potential for fentanyl-laced drugs. In the President's budget, there's roughly $40 million to combat fentanyl trafficking and disrupt international criminal organizations. What steps, Mr. Secretary, is your agency taking to prevent fentanyl from entering the United States and killing more Americans, including constituents of mine back in Ohio? Your answer, sir.
Congressman, and I want to be respectful here in the answer because you're asking me what I at HHS can do, and much of what you're asking is about the border, and that's not within the purview of the Department of Health and Human Services. I can tell you, if you wish, I know you have limited time, what we're doing with regard to fentanyl, but it won't be so much at the border. That's really Department of Homeland Security and other agencies.
Okay. So is HAS working to combat the large amounts of fentanyl-laced drugs currently circulating in the U.S.?
Absolutely. We are dedicating some $11 billion in our budget for drug overdose prevention and to try to address this as best we can, working with the states.
Just one thing I found that was interesting in the president's budget, climate is mentioned 74 times more than the word fentanyl. So just an interesting point. Real quick, I do want to just touch upon something that that we've seen particularly during the COVID time with our EMS personnel. And with the treatment in place that we've actually seen, and it's been really saving people a lot of money because, as you're well aware, our EMS personnel in the past, and currently most of our EMS personnel, are actually only paid if they take somebody to a hospital. But under this waiver program with this treatment in place, we're finding that these folks are able to actually save money by being able to diagnose it on site. So it's a good program. It's something that I know that works with your agency. I just wondered if you had any thoughts on that. You know, have 45 seconds.
And I'll be brief. It moves us more towards prevention, and rather than waiting till you send someone to the ER room and see if you can catch them before they die, it's trying to make use of the evidence that shows that certain preventative approaches can actually save lives early. And so we want to move in that direction where we can.
Okay. Thank you, Mr. Secretary. Mr. Chair, I yield back.
Gentleman from California is recognized.
Thank you, Mr. Chairman. Thank you, Ranking Member Neal. Mr. Secretary, good to see you again. Thank you for coming back and being here and being willing to answer these questions. In recent months, more so in recent weeks, we've heard a lot of reports about the spread of illicit xylazine being cut with fentanyl. Fentanyl's using xylazine to be cut and creating this drug that we're hearing that's called tranq, or zombie drug, that does some miserable things to the human body, including eating flesh and potentially leading to amputation and making the use of fentanyl cheaper, more addictive, and even deadlier. Xylazine itself is used by people for sedatives in animals, so those are licit uses. However, there's no licit purpose for it to be used in humans. That's why I've introduced my bipartisan bicameral bill today called the Combating Illicit Xylazine Act, which will help basically allow enforcement of the illicit use of xylazine under Section 21 U.S.C., as well as using the CSA under Schedule 3 of the CSA, of the scheduled drugs. I was just wanted to make you aware of that, but also wanted to see if your department is responding to the xylazine threat in any way.
I can get back to you because I can't tell you specifically what we might be doing, but we are, generally speaking, whether it's opioids, whether it's fentanyl, we have a drug prevention strategy that tries to help localities address the scourge of drugs.
Great, thank you. Moving on to Medicare Economic Index, MEI. According to data from the Medicare trustees, Medicare physician pay nationwide has increased just 10% over the last 2 decades, as you know well. Meanwhile, the cost of care increased 42% from 2001 to 2022. This type of inflation, measured by the Medicare Economic Index, is even worse in our home state of California. This month, MedPAC recommended that Congress increase physician fee rates above the current law and make an inflation-based payment tied to the MEI. A couple of questions here for you. Can you talk more about why the physician fee schedule has failed to keep up with the cost of care? Do you agree that indexing these fees for inflation is the right solution? And is there anything that we can do legislatively to correct this?
Actually, your last statement is the most operative, Congressman, because having been where you are for 24 years, I remember going through this all the time. By law, we have to make sure we level set when it comes to the payments that we make to physicians. It has to be neutral. So if you raise it here, you got to lower it here. You have to be budget neutral. And so that's one of the issues that's at hand here. We can't change that. You have to change that. And so when you ask, is there something that we, meaning Congress, can do? You have to take a look at how you want to do the reimbursement for physicians. If you're going to leave it to us, and we have to be budget neutral, we're always going to be making adjustments that hurt some and help others.
Got it. In the same note, obviously Medicare geographic adjustments, they really haven't kept up with the cost of care and created access challenges for many constituents of mine receiving traditional Medicare. Is the HHS doing anything about the geographic adjustments having not kept up with the cost of care?
Congressman, you're talking to a Californian, so fully aware. Again, where we could go, how we can do it, to some degree, we're constrained by statutory prescriptions. What we try to do is make sure we make the adjustments based on the best evidence we have in front of us.
Outstanding. Thank you, Mr. Secretary. Mr. Chairman, I yield back.
Thank you. I want to thank you, Mr. Secretary, for staying throughout the. Oh, well. You're not done yet. So we do have one more member. Before we proceed there, I would like to just say how it's great to see so many of the Alzheimer's advocates in the audience today. You can see the passion that several of our members on both sides have in regards to making sure that you have the right medicines and the cures. But it's good to see you throughout the entire hearing. Mr. Arrington from Texas.
Thank you, Chairman. My apologies for coming in late. I was balancing the budget, so I was delayed.
Congressman, you can go back and balance the budget. That's okay with me.
I know. Well, listen, my constituents would say the same thing.
Amen.
Quit talking, go take action to save this country from a debt crisis. In all seriousness, both parties have made their contributions to this runaway deficit and unsustainable debt trajectory. I say that, Mr. Secretary, because I'm not giving any party a pass on it. But before we put out our budget and our long-term vision and the values reflected in that budget framework, we are unpacking President Biden's budget. And there's a lot to unpack because it's the highest levels of sustained spending, taxes, and deficits in the history of the United States. And this, after a lot of spending, a lot of inflation, soaring interest rates, and an economy that's spiraling downward. So I'm looking for a change in direction. I'm looking for a course correction, and I see nothing but doubling down on the policies that are driving the deficit spending and the debt. And very little consideration, in my opinion, for our children and grandchildren. Because we're really borrowing on their backs and their future to pay for this stuff. When it comes to healthcare, which is a big driver and one that we all have to roll up our sleeves and figure out how do we lower cost of healthcare across the board, I was very concerned about the expansion of Obamacare subsidies in the IRA, about $65 billion worth. And now, in the president's budget proposal, I'm sure you're aware, $185 billion in more expansions. Here's the first rub for me. We're expanding to people who already have insurance, as I know you're aware. In the IRA, we only cover 1.7 million people who were uninsured. The rest of the folks that were covered, who are making, by the way, upwards of $200,000, $300,000, already had employer-based insurance. So we're spending taxpayer monies to subsidize people that are making hundreds of thousands of dollars a year. In this second round, I've read, I haven't confirmed this, that people making upwards of $600,000 are getting ACA subsidies. Now, that doesn't make sense in any world to me unless the intention is to move our country to a universal care system, to a single payer system. Is that the real, it's okay, that's a position, it's a view of the world and government's role, it's not my view, but is that, and I'm not being cute about it, is that the intention of these expansions of Obamacare to people making hundreds of thousands of dollars who already have insurance? Are you trying to move the country to a single payer system? And I yield for the answer, and I appreciate your time.
Congressman, thank you for the question. I have to start by saying that your depiction of the president's budget, I cannot agree with. Your numbers that you mentioned, I don't know where you got them. I know nowhere where anyone has ever mentioned that someone making $600,000 would qualify for Affordable Care Act coverage with subsidies. But what I can tell you is this: the president, in his 2 years in office, has reduced the deficits each year. The president's budget proposal that he put forward to Congress also reduces the budget deficits moving forward over 10 years. And so I'm not sure where you're getting those numbers, but the president's numbers are out there, whether it's Office of Management and Budget in the executive branch, or whether it's the Congressional Budget Office, CBO, which does the scoring for Congress. I remember that from 24 years here. Both have said that the president's budget would reduce deficits.
Well, I know my time's expired, and so I don't want to, I'm not going to abuse that. I'm just going to say we have a wildly different opinion about it, and but I respect your answer and appreciate your time. So I yield back, and thank you.
Mr. Secretary, in my opening statement, I highlighted the point that you all had the interaction with, $183 billion in increased funding for Obamacare subsidies, and you can make up to $600,000 a year under the president's budget, and that was in my opening statement. I do want to thank you for being here. We appreciate the opportunity that you can be before the Ways and Means members. Please be advised that members have 2 weeks to submit written questions to be answered later in writing. Those questions and your answers will be made part of the formal hearing record. With that, the committee stands adjourned.